are going to have a discussion on are the features or are the questions which are likely to be asked in your examination. All right. So let's have a discussion on this without wasting any time further. The first practical question which you are going to perform in the emergency itself, and that question is related to the skeletal traction application. So the question is that the lateral entry in the lower limb skeletal traction is avoided in all of the following except. That means, you know, when the patient comes to you in the emergency and for some reason you are going to stabilize the patient by the placement of a skeletal traction pin. Now that pin has to be inserted from the medial aspect in majority of the times, but there is one such exception where the insertion of the pin has to be done from the lateral part. Now before we talk anything related to that question, we'll come back to this question. Let's have a discussion on that what are the indications of putting a skeletal traction. I mean, what are the reasons where you have to put the patient on a skeletal traction. All right. The first one obviously is the stabilization or immobilization of the fracture. Imagine there comes a patient with a fracture in the mid 1/3 shaft of the femur, and if you don't stabilize it by putting the traction, there is a possibility of overriding, all right, of the femur if the surgery is delayed due to some reasons. So in that meantime, the perfect immobilization is achieved by the placement of a skeletal pin. Point number 2, reduction of the subluxated or the dislocated joint. Just imagine if the patient had a dislocation of the knee joint and you have reduced it, but there is always a possibility of recurrence of this subluxation until and unless you don't apply a weight tied to the distal part of the bone. All right. So reduction or subluxation of the dislocated joint. Next, maintenance of the muscle length. You know, it is also very important. Just imagine if the patient had a fracture in the shaft of femur and that fracture was neglected. Moreover, there is another possibility that that fracture was treated by, by a quack. So what ultimately it will lead to? It will lead to overriding, and once there is a overriding, all the muscles around it will also contract, and that contracture might result in a deformity which will be persistent. So in order to prevent this deformity or in order to prevent the contractures of muscles, the length has to be maintained, and that maintenance of the length is achieved by skeletal pin traction. Next, correction of the deformity. Just imagine there comes a patient who is having a fixed flexion deformity of the knee joint. All right. Imagine there is a patient who is having a fixed flexion deformity of the knee joint. Now this flexion deformity can also be corrected by the placement of a skeletal weight at the distal part of the limb. So in order to pull it out. And finally, there is a complication which is associated with the skeletal traction application for a long duration of time, or if it is not taken care of. One is that while you insert the pin inside the bone, there is a possibility of necrosis of that segment of the bone. So it will lead to loosening of the pin. And the second possibility is, is the infection, because that part of the pin which is outside the body is always vulnerable to get infected, and that infection might go all the way up to the level of bone. So that these are the two possible complications that you have to take a good care of. All right. Now, this is about the indications that we have talked about. All right. So by this, you might be having some idea that what is the role of a skeletal pin application in the human body. Now, what are the components of this skeletal traction pin? I mean, what are the components with which you have to proceed? One of the most important component is the pin. You know, we will be talking about what are the types of the pin which can be used for the purpose, but one point is pin. Now, if you look closely in this pin, that one end of the pin is pointed and the other end of the pin is where it is going to be connected to a drill or a T-handle. All right. Now this pointed end is going to be drilled inside the bone and it will go across the bone. It will come out through the bone, like is happening in this case. All right. Here the pin is inserted. As you can very clearly see that the pin got inserted from the lateral aspect and it is moved medially. So this is how the skeletal pin traction is applied. Then this pin has to be connected by a now this pin has to be connected by a bowler stirrup. All right. So this is bowler stirrup of variable sizes. You might be having this bowler stirrup. Then these are the drills which can be used for the purpose. Ideally, a very high RPM drill is avoided because it might result in the necrosis of the entry segment of the bone. That is why a T-handle is required. All right. That means this is a T-handle, obviously. And this is the battery drill. So both these two can be used, but drill has to be used with a less RPM, all right? So that if you are going to drill it with the maximum rotations per minute, then there is always a possibility of this energy to be transmitted inside the bone, which might produce excessive heat at the site of contact, and it might result in the necrosis of that segment of the bone where which you are inserting the pin. Hopefully everything is clear related to the components. And finally, all these weights are tied by the pulley. Now, by using the skeletal traction, we can actually pull the body weight with the application of around 15 to 18% of the body weight. All right. That means the weight which can be used in case of a skeletal traction can extend all the way up to 20% of the body weight. So much of the force can be applied in order to achieve the greater correction of the deformities. So with this, you came to know everything related to the skeletal traction, which might be kept, which you have to think while performing this procedure inside the emergency itself. But before we talk anything related to the indications, next let's talk about the question back, that the lateral entry in the lower limb skeletal traction is avoided except, what are the sites where you can put the pin? I mean, it could be a distal end of the femur, it could be a proximal end of the tibia, it could be the distal end of the tibia, or you can also insert the calcaneal pin. Now, just now you came to know that the pin basically is having one end pointed through which you are going to gain the entry inside the bone, and the other end which is there for the connection with the drill. Now, if you put the pointed end from the lateral part, all right, if you gain the entry from the lateral part, there is always a possibility that this pointed end will be emerging out of the medial aspect. And once it emerges out of the medial aspect, there is always a possibility to hurt the other limb through this pointed part, all right. That is the reason why this pointed part is most of the time kept laterally through the medial entry. So majority of the time what you do, if you are inserting a pin in the distal end of the femur, for example, if this is the distal end of the femur and you are putting a pin from the distal end like this, so it is usually coming from the medial aspect, all right. From the medial part, you will gain the entry and it will exit out from the lateral part, so that the pointed end remains laterally. It is not going to harm the body. Moreover, it is covered. All right, you cover it after some duration of time. But there is one exception. Exception is the proximal aspect of the tibia. Now, this proximal aspect of the tibia, when you insert the pin in the proximal aspect of the tibia, this is considered to be an exception. What is the reason? The reason is simple, that common peroneal nerve injury. In order to prevent the common peroneal nerve injury, the thing is that imagine this is the proximal aspect of the tibia, which is visualized from the lateral view. All right, this is the proximal aspect of the tibia from the lateral view. So the thing is that this is the tibial tuberosity, and you mark a point which is around 2.5 centimeter distal and 2.5 centimeter inferior to the tibial tuberosity. So this is the point where you will make the entry for this skeletal pin. All right, thereby you are avoiding any possible injury to the common peroneal nerve. So lateral entry in the lower limb skeletal traction is avoided in all of the following except, so that exception is the proximal aspect of the tibia, because in proximal aspect of the tibia, if you go from the medial insertion, there is a possibility that you might hurt the common peroneal nerve on the lateral aspect. So that is why it is taken care of. Hopefully everything is clear related to this particular question and the explanation associated with it. Now, what are the names of pin which are utilized for the purpose of skeletal traction application? The pin basically are of two types. The most commonly used is the Steinmann pin. All right, the most commonly used is the Steinmann pin. On the other hand, less commonly used is the Denham pin. Now, what is the difference in between these two? Now, point number one, what are the similarities? The similarities, obviously, one end has to be pointed, other end where the drill is connected. Similarly, in this case also, the one end is the pointed end and the other end the drilled end. But what is the difference in between the two? The entire surface of the pin in a Steinmann one is smooth. So it's a smooth pin. On the other hand, we are having the central serrations in case of Denham pin. So there is a possibility that we are having a central serration. There is a provision of a central serration in the middle segment of the Denham pin. Now, what is the reason why we are putting this central serration in the middle of the Denham pin? So in order to get a better cortical purchase. Just try to understand, if this is a bone, all right, and here you are putting inside the pin. So these are going to have the central serrations in order to have the better cortical purchase, and that better cortical purchase is required in case of elderly. So Denham pin, the indication for use of this Denham pin is provision of the skeletal traction in elderly or pathological bones. That means weak bones. Hopefully everything is clear. There is always a possibility that they can give you this Denham pin in the picture, and then they will ask you what is the name of this pin, what is the indication of this pin. So both Steinman and Denham pin are used for the provision of a skeletal traction, but Denham pin is used in case of elderly because of the weakness of the bone. So to prevent the loosening of this pin, in order to have the better cortical purchase, we are using Denham pin. On the other hand, majority of the time, Steinman pin is used for the purpose of skeletal traction application. All right. So that was about the question number 1. You know, skeletal traction application is your part, means after completing your MBBS, you are asked to perform this skeletal traction. You are asked to stabilize the patient, and you should be taking everything care of each and everything. Next question is related to the open fracture. Like when you are in the emergency and you see a patient and the patient is having an open fracture, that means the fracture is exposed to the external environment. Then in that scenario, what is your duty, all right, or how you should carry out the stability of the patient, or what are the things that you should be taking care of? So just first of all, imagine open fracture means that the bone is exposed to the external environment. And you know, when the bone is exposed to the external environment, it is the result of a high velocity trauma. It is going to have variabilities in the form of bony pattern fracture, and it would be relatively having a poor prognostic outcome. So there are multiple factors which are taken into account in order to decide that what is going to be the prognosis for that particular patient. So let's talk about, or let's start with the question that which of the following is not true in context or in relation to the open fractures. So option number 1 is that the periosteal stripping dictates the poor prognosis. You know, this statement is true. In our classes, we have talked about that open fractures are basically categorized by Gustello-Anderson system of classification into 3 different types. And this type 1, Gustello-Anderson, is going to have a relatively good prognosis. The type 3 would be having a poorer prognosis. So type 3 is always associated with some amount of periosteal damage. Now, how this periosteal damage, if it is present, will alter the prognosis, you know, because the periosteum, all of you are aware of the fact that periosteum basically is not just a fibrous layer which is covering the bone. Periosteum is basically made up of 2 layers. The inner layer, which is cambium layer, and the outer layer, which is fibrous layer. And you know, this inner cambium layer of the periosteum has got osteoprogenitor potential. So if periosteum is stripped, then this segment of the bone which might help in the union achieved is lost. So obviously it is going to have the poor prognostic indicator, or it is going to have the poor prognosis if the periosteum is stripped. Next, external fixators are preferred for severe injuries. Again, it is very commonly observed that, you know, if the patient is having a open fracture, there is extreme loss of his skin, the bones are exposed, you obviously are not going to perform the internal fixation, or the internal fixation is avoided. Why? Because of the failure of this implant as far as infections, non-unions are concerned. So better first to take the care of the wound by the provision or by the placement of the external fixators. Once the wound is healed, once you think that there is not going to be any infection, once you think that the non-union is going to be taken care of, then you can go for the permanent or the definitive management by the placement of internal fixation devices. All right. So external fixation are required for the provision of initial stability to the patient when they are having the open injuries. You know, these are the kind of the questions which previously were asked in the form of one-liners. They used to ask like open fractures are best managed by. So answer for that question was wound debridement and external fixation application. But today they are going deep into the details of those external fixation devices also. You know, if you look at the external fixation device, what do you mean? Imagine this is a bone. All right, this is the tibia we are taking the example of, and there was a fracture in between, and this tibial bone has to be managed by placement of external fixation device. Now, the pins which are used for the placement of this external fixation device, this pin is going to have the serrations at the end, and this pin is different from a Steinman pin. This pin is different from Denham pin. all right, because there are serrations for the cortical purchase provided at the end of the bone, and the name of these pin is Schanz pin. So the pins which are used for the provision of the external fixation device is the Schanz pin, while the pins we were using for skeletal traction application were Steinmann and Denham's, and this is how they are being differentiated. So when you insert multiple pins inside the bone, and all these pins are then connected by an external rod, so this is known as external fixation, all right. So you are stabilizing the bone. In the meantime, the wound is going to be taken care of. Once the wound is healed, then you can go for the definitive management, all right. Now, as far as stability is concerned, there are various planes in which this external fixator could be provided. Obviously, uniplanar means in one plane, biplanar means in two planes, all right. So biplanar fixation is going to have the better stability compared to uniplanar fixation. So these are the things that could be kept in your examination just in case, all right. So the option 2 is also true. Next comes the option 3, that compartment syndrome are common. Obviously not. You know, when the fracture is open, you are aware of the fact that if there is a collection of too much of the blood inside the compartment, then it will result in the compression of all the structures inside that compartment, and it will result in compartment syndrome. But in case if you are talking about the open fracture, so with the initial event, until and unless it is not too much complicated with the secondary infection, the possibility of compartment syndrome is relatively less in the open fractures. As I told you, until and unless it is not related to the secondary complications like infection. So this particularly is the answer for this particular question. And next comes the higher chances of infection. This is something that we have already talked about. You know, if the fracture was open, there is always a possibility of this bone to get contaminated because of the periosteal stripping, because of the loss of the vascularity. So all these things will promote infection at the site of the fracture. So hope everything is clear related to this particularly conceptual questions, or just on the basis of the learnings that you had previously, you have to mark this answer right, all right. Let's talk about another question, that a 32-year-old patient presented in the emergency. Imagine if the patient is 32-year-old, he presented in the emergency after sustaining the injury to his right hip, all right, following the road traffic accident on the car, which he was riding as a front seat rider. All right. So the patient has sustained injury to his right hip. He was riding on the front seat, and on examination, so in front seat riding means there has to be a collision, and because of that collision, the patient has sustained injury to his hip joint. Now on examination, the right thigh was fixed in adduction, flexion and internal rotation. Now this is something which we have already talked about multiple of the times, that you know, if they give you an injury related to the hip joint, and if the specific attitude of the patient is provided when the patient is present on couch, when the patient is presented to you on couch, then it is possibly because of the dislocation of the hip joint. And you know, dislocations of the hip joint, as far as you need to remember, are categorized into two, like one is posterior dislocation and the other one is anterior dislocation. If the hip joint is dislocated posteriorly, you know, if the hip joint is dislocated posteriorly, then this patient would be having the flexion, adduction and internal rotation deformity. You know, or the reasons why there is going to be flexion, why there is going to be adduction and internal rotation, because of the posterior dislocation of the hip joint or the posterior dislocation of the head of the femur in relation to the acetabulum. Moreover, this posterior dislocation is further assisted by the mechanism of injury that has been provided in the question. You know, the mechanism of injury which they have provided is when he was riding in the front seat of the car. Imagine there is imagine if the patient is riding in the front seat of the car and there are sudden application of the brakes. So the knee will strike against the dashboard, and the force, the counter force which is knee is facing, will be transmitted all to the hip joint, and it will result in the posterior dislocation of the hip joint. So this is basically the answer for your question, that you know, the mechanism of injury is the dashboard injury. All right, this is obviously, we are aware that dashboard injury is the mechanism of injury. So they have provided you the mechanism of injury, they have provided you the attitude on the basis of which you have provisionally made the diagnosis. All right, so the diagnosis is posterior dislocation of the hip joint. All right, now any movement, now you further proceed with the question, that when you perform any movement at the level of hip, all right, when you try to move the hip, the condition is extremely painful, and obviously all the movements are going to be restricted. So there was no open wound. Now what next? How to proceed further? So basically what the question is, that the you are given with the scenario that there is a patient with a posterior dislocation of the hip joint. Now how you have to manage him. All right, there are options provided. Point number 1, CT scan. First you perform the CT scan, then go for closed reduction and immobilization. Remember, these sophisticated investigations are meant to be delayed until and unless the indications becomes mandatory. Again, I'm repeating my statement that these sophisticated investigations are basically delayed until and unless the indication becomes mandatory, because today the examiner is not asking you to get dependent on these sophisticated investigation. You have already diagnosed the condition. All you have to look for is there any associated fracture around the hip joint? So this can also be ascertained, this can also be managed by performing a simple X-ray. On the X-ray, for example, there comes a fracture of the acetabulum, which you need to know that whether it is involving the anterior or the posterior column, then there is a requirement of the CT scan. So hopefully you get the answer. What I'm trying to say is that first you have to perform the CT scan, obviously not. Closed reduction and immobilization, obviously not. So it is the X-ray you have to go for. Then go for open reduction and immobilization, and this particularly is the answer for your question. All right. So you have to go for open reduction, X-rays. On the X-ray you have diagnosed it. Then you have to perform the closed reduction. After reducing it, you have to immobilize the limb by the placement of a traction. All right. So that is the correct procedure. Now, in that X-ray, if there is any associated fracture which requires CT scan to become a mandatory investigation, then you have to go for CT. So it is always a secondary investigation. Next, what are the other options? Other option like open reduction, obviously not. First, you have to try for closed reduction. If at all this thing is not happening, then you have to go for open reduction. Then MRI, then open reduction, obviously not. As I'm saying it repeatedly, that today examiner does not want you to answer the MRI or the CT scan or any sophisticated investigation immediately. You have to talk about these investigations later. Next, so what is going to be the attitude for anterior dislocation of the hip joint? You know, there is another condition like anterior dislocation of the hip, and in anterior dislocation of the hip there will be flexion. To some extent there will be a flexion. You know, it all depends upon that in which position the patient is more comfortable. The patient can have the flexion or to some extent the extension also. But the relatively differential point is abduction and external rotation. All right. When the patient comes to you with the anterior dislocation of the hip joint, there is abduction and external rotation. One more point of difference in between is that, you know, the posterior dislocation of the hip, it presents with the shortening of the limb. It presents with the shortening of the limb. Shortening because the head of the femur has migrated proximally, so there will be an overall shortening of the limb. On the other hand, the anterior dislocation of the hip joint, there is no shortening, and the reason for this no shortening is that, you know, the proximal migration of the head of the femur, which is dislocated, is prevented by the rectus femoris muscle. Anteriorly we are having a rectus femoris which prevents the proximal migration of the head of the femur. That is the reason why there is no observable shortening of the lower limb. So hopefully everything is clear related to this very important question which they have been asking again and again. Next question is again a clinical question provided to you as if you are standing in the emergency, and what you have to look for. A 27-year-old worker sustained the electric shock. Now we are talking about the electric pole worker. Sustained an electric shock, fell from pole. On gaining consciousness, he experienced intense pain in his right shoulder and the arm was fixed in adduction without any abnormal mobility. That means abnormal mobility somewhere in the mid part of the limb is representing the possibility of fracture, all right, with intact distal neurovascular status. So everything is clear. Now what are the two catch points in this question? The first one is the mechanism of injury, which they have clearly provided, that he was working on the electric pole, sustained an electric shock and fell. And second is he experienced intense pain in his right shoulder with the arm kept in adduction, all right. So this is the attitude with which the patient is presenting to you. What is the most probable diagnosis, investigation and possibly the management that you have to proceed with? First of all, before even we talk about this, what we will think that possibly the patient is having the posterior dislocation of the shoulder. The patient has sustained possibly the posterior dislocation of the shoulder. Now, why are you saying this posterior dislocation of the shoulder? Point number one, the mechanism in the form of a hint which is provided to you in the question. It is electric shock, and as I told you that one of the key reason for posterior dislocation of the shoulder is either the electric shock or the seizures. All right. If the patient is experiencing the epileptic seizures, so these are the two potential reasons, causes for the posterior dislocation. And second is that the arm was held in adduction. You know, the attitude for anterior dislocation of the shoulder is adduction and internal rotation of the arm. So the arm is kept in adduction and internal rotation. All right. So these are the two things on the basis of which you have provisionally diagnosed that the patient is having posterior dislocation. Now, how will you confirm it, or how will you proceed with this situation? Point number one, is it the anterior dislocation of the shoulder that you have provisionally diagnosed? X-ray or closed reduction? Obviously not. Then inferior dislocation of the shoulder. You know, inferior dislocation of the shoulder is when the patient presents with the overhead abduction of the arm. Anterior dislocation of the shoulder is when the patient presents with flexion, abduction and external rotation. All right. So both these two options are dicey, means you have not confirmed it yet. Next, is it the posterior dislocation of the shoulder? Yes, it looks like. X-rays, yes, X-rays are going to be helpful. And closed reduction has to be attempted, yes. So this possibly is the best answer for the question in the form of this scenario provided to you, that this possibly is the posterior dislocation. You have to confirm it by the X-rays done, and once you have confirmed it, you just have to attempt a closed reduction. All right. Now, next point is dislocation of the shoulder to be diagnosed with the MRI. Obviously not. MRI has to be delayed as much as possible as until and unless it is required to get the MRI done to look for the secondary complications. All right. So that possibly the option C is the best answer. If you look at the differences on the X-rays, that means how will you come to know about anterior or posterior dislocation? You know, this is anterior dislocation of the shoulder, which is very clearly visible over here, that the head of the humerus is out of the glenoid and the humerus is kept abducted. All right. So this is anterior. Now, what are the X-ray findings which might suggest that possibly the patient is having a posterior dislocation of the shoulder? One of the X-ray finding is the rim sign. Rim sign means, you know, empty. This glenoid seems to be empty. It is not articulated. Like if this is the glenoid cavity, the head of the humerus is having a perfect articulation with the glenoid, which is missing in this kind. Point number two, there is light bulb sign. The proximal humerus, because it gets internally rotated, it appears like a light bulb. All right. So this appears like a light bulb sign. And finally, the space, yes, empty glenoid, rim sign is basically the increased space between glenoid and the head of humerus. All right. And as I told you that there is an empty glenoid, that the head of the humerus is out of the glenoid cavity, so there is lack of articulation and it appears like an empty articulation. All right. So empty glenoid is also a feature for dislocation of the shoulder, anterior dislocation of the shoulder. So these are the things which you have to take care of in between the anterior and posterior dislocations of the shoulder. All right. So hopefully everything is clear related to that question also in the emergency. Next question is a 26-year-old admitted patient. Now the patient is already admitted having a fracture in the right femur, right tibia and fibula, with the left femur developed fever. Now, the patient, what is the first point that is being mentioned over here? That the patient is having a fracture in the long bones and multiple long bones are fractured. The patient developed fever, all right, and increased respiratory rate. Now, for example, on third day, the patient has developed fever and respiratory rate. It raises the alarm that possibly the patient is landing up in, all right, it raises the alarm that possibly the patient is landing up in fat embolism syndrome. As you know, that fat embolism syndrome is associated with the fractures in the long bone. You see, hint in question that long bones are fractured. Point number two, the alarming clinical features are tachypnea, tachycardia and fever. Now, this is something that you have to take care of, all right, because you are going to measure the blood pressure, you are going to measure the temperature as well as heart rate of the patient. Now, such a patient developed these alarming features, possibly he is landing up in fat embolism syndrome. Now, how to confirm it further on examination? You know, when you told it to your senior that the patient is having these kind of increased respiratory rate and fever, so what you will do, he will try to have a petechial rash, or he will try to have a look on any rash, any kind of a rash which he might have developed onto the trunk, abdomen, axilla or conjunctiva or retina. Now, on examination, he was found to have a petechial rash over trunk and abdomen. That means it is confirmed that the patient is suffering from fat embolism syndrome. If you further try to confirm it, the pathognomonic sign for fat embolism syndrome is the presence of the petechial rash. All right. So what are the sites? It is abdomen, trunk, conjunctiva as well as retina. So which of the following is incorrect for the condition? So first of all, the condition you have already diagnosed at that it is fat embolism syndrome. All right. Now, which of the following is incorrect for this particular condition? Incorrect. All right. Point number one, option number one, that get a valid consent with unprecedented outcome. Obviously, yes, that you have to explain it to the attendants of the patient that he might lose life also, although we are trying, because the complication of fat embolism syndrome has started, because it might ultimately result in the coma, respiratory distress, and even death of the patient. All right. Point number 2, put the patient on oxygen assistance. Yes, it is required. Then check the fracture stability, obviously, because if the fractures are kept or rendered unstable, imagine the patient is admitted, he is having instability at the site. So there is always a possibility that the fat emboli will reach the more and more of the fat emboli would be released. So you have to check for the stability. And finally, delay the fixation or the treatment of the fracture. Now this is something which is considered to be controversial, but you should not delay the fixation in case the patient is having these kind of the possibilities, because it might further result in the release of the fat emboli globules, and it might increase the possibility of the pulmonary emboli. All right. So it is better to perform the fixation. All right. Although it depends upon the priority of the surgeon who is treating upon the patient. So as far as management controversies are concerned, previously it was thought that, if you are going to fix the long bone, you have to ream the bone, and in the process of reaming, more and more of the fat globules will reach the circulation. But multiple studies have suggested that you don't ream it, you just put the nail inside, or you just fix the bone, all right, without reaming the bone. So this process of fixation will arrest the possibility of the globules which are getting released into the circulation. So better to fix the patient, although it depends upon multiple factors, all right, but it is not a contraindication anymore. I mean, fixation of the fracture is no more a contraindication as far as this fat embolism syndrome is concerned. So hopefully this point is also clear. I mean, you just have to look at the question, you have to identify the possibility that he might be suffering from, and then you have to mark the correct answer related to it. Next is next question is, the patient with a fracture of the both bone right forearm was admitted for surgery. All right, the patient was admitted for surgery with the above elbow slab. So you have stabilized by the placement of the above elbow slab, and there is a fracture of the both bone on the mid 1/3. That means radius and ulna are fractured. Now third day on round, professor noted excessive swelling in the fingers. Third day there is too much of the swelling, which is relatively discomforting for the examiner or for the professor. On extension of the fingers, the patient experienced intense pain. Now by this time, which you have already came through, if you have already studied about compartment syndrome, by this time you have already made the diagnosis that the patient is suffering from the compartment syndrome. All right. Now, or the patient might be having a impending compartment syndrome, that over a period of time it might change into a compartment syndrome. So what next? I mean, what is the next best thing that you will do? All right. So if you look at the option, point number 1, measure the intracompartmental pressure. Obviously not. There is no role of measuring the intracompartmental pressure if you are suspicious that possibly the patient will be landing up in compartment syndrome. It's not going to help you out in the management, all right? Intracompartmental pressure management. You don't waste your time in the measurement of the intracompartmental pressure. You just start doing it in order to prevent the development of the established compartment syndrome. Perform open reduction internal fixation? Obviously not, because if you open this kind of a skin, if you penetrate all the way up to the level of bone, you are further causing an injury to an inflamed structure, to a compressed structure, and it will incite more inflammation, it will invite more inflammation, and the results are going to be deleterious for the patient. So better avoid performing any incision to the patient. Fasciotomy. Fasciotomy is important in the earlier stages of compartment syndrome. When the patient is having a compartment syndrome immediately because of the fracture, or internal compartment syndrome is there, internal reasons are there for this compartment syndrome, you perform fasciotomy, and that too within the duration of 6 hours from injury. But if it is delayed, if muscles are already compressed to an extent that if you perform fasciotomy, it will result in reperfusion, and that reperfusion is not going to help the muscles. It will further invite the inflammation, and it will further cause the necrosis of the patient. All right. So hopefully you have understood that fasciotomy in late stages of compartment syndrome, or the patient or the late development of compartment syndrome, is not going to help too much. So what next you are left with? Check the skin. Obviously you have to open the slab first of all. Check for the skin lesions, because there could be a presence of blebs. Those blebs, if are there, they have to be managed. All right. Reapply the slab. Now this time you are going to reapply a slab loosely, because this possibly is because of a compartment syndrome from the extensor or from the extrinsic compression. and start anti-inflammatory drugs or the antibiotics. So relevant anti-inflammatory or antibiotic drugs are meant to be started in order to control this excessive swelling and establishing the compartment syndrome. So hopefully you get the best possible answer for the scenario if you are projected with. That is the answer for your question. As far as something, if you want to learn about compartment syndrome, then why fasciotomy is avoided in late onset syndrome, as I told you that it will result in vicious inflammatory cycles. All right. It will further invite the inflammation. It will cause more and more inflammation of the bone and of the muscles, and it will the prognostic outcome is going to be relatively poorer. Point number 2, what are the indications for performing the fasciotomy? You know, the best indication is the clinical suspicion. Now, if you have to perform a fasciotomy, like the patient coming in the emergency having excessive swelling, so just on the basis of the clinical suspicion, you will perform the fasciotomy. That is the best indicator. It is being done throughout in all the emergencies related to orthopedics. Next, what is the theoretical indication? I mean a bookish indication. What is that bookish indication that you will consider for performing a fasciotomy? So it is that the difference between the mean arterial pressure, and intracompartmental pressure. You know, if the difference in between the two, for example, the patient comes to you with the injury having a possible compartment syndrome, then what you do, you will measure the mean arterial pressure of the patient and you will measure the intracompartmental pressure of the patient. Now, if the difference in between the two is less than 40 millimeters of Hg, then perform fasciotomy. It means that the intracompartmental pressure is progressing towards mean arterial pressure. All right, so it will result in a permanent occlusion of the vascularity, thereby causing compartment syndrome. There is another indication which you might have read, that if the intracompartmental pressure is less than 40 millimeters, greater than 40 millimeters, perform fasciotomy. Now that is not a correct indication. You know, you cannot use this same figure of 40 millimeter of Hg and apply universally. So this is the better indication for performing fasciotomy. That means the difference in between the mean arterial pressure and intercompartmental pressure is less than 40 millimeter of Hg, then you perform the fasciotomy. So it is a theoretical indication. Otherwise, if the examiner asks you that which one is the best indicator for performing fasciotomy, it is the clinical suspicion. All right, all the clinical features you should be aware of. Hopefully everything is clear related to that question also. Next question is that 27-year-old came to casualty after sustaining injury to his left elbow with the forearm. All right, forearm and elbow, both of them are injured. Radial pulse and hand sensations were intact. Pulsations as well as the hand sensations, there was no sensory loss, were intact. But extension of the fingers were lost. That means when you ask the patient to perform the movement, extension of wrist was normal, extension of finger were lost. Now x-rays were done. What is the diagnosis that the patient could be suffering from? So first of all, you have to look at the x-ray and decide that what is the kind of the fracture, what is the kind of the injury that the patient has sustained. Now if you look at the x-ray, you are having a fracture of the proximal aspect of the ulna. So there is a fracture of the proximal ulna, it means ulna in the proximal part, and the radio-ulnar dislocation. So there is a radio-ulnar dislocation. You know, when you combine both these two facts, that means if there is a fracture in the proximal part of the ulna with proximal radio-ulnar subluxation or dislocation, it is actually the Monteggia fracture dislocation that you are talking about. So first thing that you came to know, that it is Monteggia fracture dislocation. So answer for this question could be either B or D. All right. Now, the possibility was also there that he could be suffering from a nerve injury. Now, you know, before we talk anything related to this nerve injury, let's have a discussion on a radial nerve injury to some extent. Now, the name of the bone with which this radial nerve is attached or it is related to is the humerus. Now, all of you are aware of the fact that humerus it is related to. If the medial part and this is the lateral part. Now, how the radial nerve is related? That the radial nerve descends medially and then it descends laterally. And just at the level of elbow or above the level of elbow, it divides into the posterior interosseous nerve and superficial radial nerve. All right. So based on the level of the involvement, the radial nerve can have different clinical features, different clinical outcomes. Like if the radial nerve is injured in the proximal part, that means above the level of a spiral groove. This is the spiral groove. All right. If it is injured above this level, then what are going to be the features? If the radial nerve is injured above the level of a spiral groove, there will be a loss of extension in the elbow, wrist and metacarpophalangeal joint. Everything is going to be lost, all right? But if the radial nerve is injured below the level of a spiral groove over here, then elbow extension is preserved. Elbow extension is not lost. There will be a loss of wrist extension as well as metacarpophalangeal joint extension. Now, some of you might be asking that, if the same nerve, that is radial nerve, getting injured, then why if it is having two different types of clinical outcomes? If the nerve is injured above the level of a spiral groove, it has already given its branch to the triceps. So the tricep function would be normal, elbow extension would be preserved. And in case one of the motor branch of the radial nerve is injured, that is posterior interosseous nerve, there will be a loss of extension of the metacarpophalangeal joint only. Then what is the other difference in between the posterior interosseous nerve injury and the other common radial nerve injury is that posterior interosseous nerve is a pure motor nerve. It is a pure motor nerve. It has got no sensory inputs, and when the nerve is not having any sensory supply, there is going to be no sensory loss. So if you go back to the question that if it is a Monteggia fracture dislocation, whether associated with the radial nerve injury or a posterior interosseous nerve injury, then the answer for this question is with the posterior interosseous nerve injury. Why? Point number 1. Associated with Monteggia fracture is a posterior interosseous nerve injury. Point number 2, sensations in the hand were intact and there was a loss of extension of the metacarpophalangeal joint only. So when you combine all these facts, you will come to know that exactly it is a PIN which is likely to get injured in the Monteggia fracture dislocation. Hopefully this point or this question is also clear. Now there is something that you should also be aware of, like you should be aware of Galliazzi fracture. It is the fracture of distal radius with distal radial nerve joint subluxation or dislocation. You should be aware of this acromion fracture dislocation, which is the fracture of the it is the fracture of the proximal part of the ulna with distal radio-ulnar joint disturbance or distal radio-ulnar joint subluxation. All right, fracture of the proximal part of the radius, with distal radio-ulnar joint abnormality is acromion fracture dislocation. So hopefully this question is also clear. I mean, this question is relatively simple. I mean, there is not too much of the complications once you are aware of what exactly happens in the human body in the form of the anatomical correlation. All right. Next question. All of the following fractures of the foot. Now, just imagine, you might have seen this also if you are working in the emergency. If there is any fracture of any bone in the foot, then majority of them are treated by the placement of a below knee cast. All right. Below knee cast immobilization will suffice. I mean, it is more than enough. And over a period of time, there will be healing. After some time, there will be swelling, there will be pain, but it will start subsiding over a period of time. But there is one indication where placement of this cast only is not going to help it. So all of the following foot fractures are treated by closed reduction and below knee cast immobilization, except that means operative treatment is required for only one fracture. And what is the name of that fracture in the foot where only operative treatment is required? And the answer for that question is fracture base of second metatarsal. And the fracture base of second metatarsal is also known by the name of Lisfranc's fracture dislocation. It is Lisfranc's fracture dislocation. Now, how this Lisfranc fracture dislocation is different from the management of the others, just try to understand. Imagine this is first, second, third, fourth and fifth metatarsal. The first, second, third, fourth and fifth. All right. Now, all these metatarsals are connected by a intermetatarsal ligament. There is an intermetatarsal ligament in between 2 and 3, 3 and 4, 4 and 5. But there is no intermetatarsal connection in between 1 and 2. So if there is a fracture over here in the base of the second metatarsal, then this entire ray of the metatarsals will be dislocated from the proximal part of the tarsal bones. So in order to achieve this reduction, you have to open this fracture site, and after opening it, you have to fix it by the placement of a Herbert screw, simple cortical screw, compressive cortical screws, or by the placement of the K wires in the direction of the Lisfranc's ligament attachment. So this is how it is different from all the other types. In all the other types, the treatment was done by conservative methods, but here the treatment has to be performed by open reduction, internal fixation. That is the only exception, and there is a reason for this exception. Now, another point is that, this question we were teaching with the hope that they are going to ask this question, and they have asked this question in INI CET examination in the most recent one in 2022. They have asked this question about Lisfranc fracture dislocation. All right. So hopefully you have understood the importance of this. Next, they have asked this question also that, it is a common scenario. It is a day-to-day scenario which might happen with you also, that in case the patient is suffering from a frostbite, all right, and this is a kind of the patient which might be having lost all the sensations in the finger, and you have to prevent the amputation. Rather, what is the method with which you are going to help the patient out? So this is actually the only indication where you should not perform amputation. That is the correct answer. You will never perform amputation immediately. Immediately what you will do, first of all, remove the clothings. Imagine there is a patient who might be having suffering from frostbite. You have to remove the wet clothings. After removal, rewarming, immediate rewarming is most important. After removal or after treating hypothermia, immediate rewarming is most important. Remove wet clothing, and yes, silver sulfadiazine or the antibiotics or the anticoagulants, all these are required in the form of the medicines which could be given. But yes, initial amputations are to be prevented as much as possible. So that is the answer for this question. This one is the answer. All right. This is actually the exception where you will perform no amputation despite the fact that you are having no sensations left, you are having no vascularity left, you have having no movement left. You just have to wait because it might result in the revascularization after some duration of time. All right. This is also a question which they have asked in INI CET examination, just recently. I mean, they have asked this question about frostbite, that you should not perform amputation immediately. How to treat the condition. This is a day-to-day condition. Next. Now, this is something which they are going to ask you. Out of this slide, one question is they are going to ask. And at this point of time, when we have, if you read the previous year questions, you might have studied everything related to Colles fracture. So there is nothing which you have to leave. Elderly patient, abnormality in the wrist after getting fractured. How to treat or how to manage this condition by the placement of the Colles cast is something that you should be aware of. All right. We are not going to have a discussion deep into the details because this is something which is very, very commonly asked. You should be aware of everything related to Colles fracture. What are those things? Point number one, the definition. Point number two, the abnormalities in the wrist. That means displacements. That is dorsal displacement. The dinner fork deformity. Point number three are the complications. And point number four, how to manage this condition. What is the placement of the cast? What is the direction in which the distal radius is immobilized? All right. You should be aware of this. Similarly, you should also be aware of every complication related to supracondylar fracture of the humerus. Like there could be anterior interosseous nerve injury, there could be a brachial arterial injury, there could be compartment syndrome, there could be myositis ossificans, and most importantly, there could be a cubitus varus abnormality or gunstock deformity. All right. So this is something which we are not talking in detail, but yes, they are going to ask it. They have asked it hundreds or multiples of the time. And in this revision class, we are not going to discuss it in detail, obviously. You should be aware of this. As far as scaphoid fractures are concerned, don't waste your time in having a discussion of entire anatomy. You just have to focus on the complications, all right? The possible complication, that means the non-union and the avascular necrosis of the proximal pole of the scaphoid. So these are the complications. Whenever they ask a question related to scaphoid, they will ask the answer related to complications, all right? And so is the case with the fracture neck of talus also. You know what happens in fracture neck of talus? There are a complication related to precarious vascularity, that is non-union, as well as the avascular necrosis of the talus. So these are the some of the things that you have to revise on your own. So many times they have asked this question. I mean, there is no way of avoiding these topics, all right? Hundreds or multiples of the times they have asked these questions in the form of one-liners majority of the times, all right? All right, next, come to the another very critical scenario, that there comes a patient who might have suffered the anterior cruciate ligament injury, all right? So there is a patient who is having an ACL injury. What immediately you have to do? All right, acute immediate ACL injury, which of the following is incorrect? What you should not perform in that scenario? Point number one, it is a result of the valgus of the knee in external rotation and flexion. Actually, this is the mechanism of ACL injury. You know, this is the mechanism of the anterior cruciate ligament injury. And this mechanism is responsible. It is the most apt mechanism. Like if the one who is playing a soccer or a basketball kind of the game where it requires a immediate rotation is required, then there is a possibility of this anterior cruciate ligament injury. You see, when the knee is flexed to around 10 to 15, 20 degrees and it is kept in external rotation, and there is a sudden valgus force which is applied to the knee joint, all right? That means internal deviation of the knee happens. Then it is considered to be the most apt description for the mechanism for ACL injuries. So this option is true. Lachman test for provisional diagnosis. As far as the test for the anterior cruciate ligament injuries are concerned, one is the Lachman test over here and the other one is anterior drawer test. Now what is the difference in between the two? The major function of the anterior cruciate ligament is to prevent the anterior translation of the tibia. This you might be already aware of. Now in case if the patient is having a complete ACL injury, that anterior translation becomes prominent because ACL is not there to prevent this anterior translation. So there are two ways of conducting this anterior translation. One is to keep the knee flexed into 20 to 30 degree. Other is to keep the knee flexed in 90 degree. So in anterior drawer test, the knee is kept in 90 degree, while in Lachman test, the knee is kept in 20 to 30 degrees of flexion. Immediately after injury, there is too much of the blood which has already been collected inside the knee. If you flex the knee to 90 degree, it will result in massive hemarthrosis. It will result in massive pain to the patient because you are further compromising the knee space. So the condition is going to be extremely painful. On the other hand, in case of Lachman test, what happens? You are flexing it to just 20 to 30 degrees. All right. The condition is going to be painful, but not up to the level that the patient will scream. So Lachman is considered to be the sensitive test performed in immediate situations. All right. So this is, yes, Lachman test is for provisional diagnosis. This is also true. Next, immediate MRI. As I told you multiple of the time, be aware of these type of the options. Immediate MRI. It is true that MRI is the investigation of choice for anterior cruciate ligament injury visualization. But imagine if the patient has immediately sustained injury, then there is too much collection of the blood and that hemarthrosis will impede the real visualization of the ACL tear. That is why ACL tear MRI or MRI related to ACL tear is delayed until and unless the swelling inside the knee subsides. All right. So this is probably the answer for this question, that immediate MRI is never the answer. True, MRI is the investigation of choice, but it has to be delayed. Next is knee brace and rest. Full weight bearing can be allowed. Yes, you will apply a knee brace. You'll ask a patient to take the rest. Appropriate drugs are given, and you ask the patient to wait. You can bear weight on the affected limb by the placement of this knee brace, even immediately after injury. All right. So immediate MRI is something which is prevented, and you came to know that what is the reason. Hopefully everything is clear related to this clinical scenario of anterior cruciate ligament also. Next, yes, we are going to talk about several of the differential diagnoses which could be provided to you in the form of a question. Now, first differential is that of a low backache in case of a young individual. And these two differential diagnoses, one is ankylosing spondylitis and the other one is Pott's spine. So how you are going to differentiate in between the two? You see, both these two are going to be presenting with the similar clinical features like young age, there will be low backache, a long history is going to be there. All right. There will be limitation of movements also, some extent disability also. So young age, back pain, long history, everything will remain common. All right. Fever and the limited movements. Fever is a feature of more inclined towards the Pott's spine, but although even in case of patients suffering from ankylosing spondylitis, you can have the episodes of fever. But what are the basic differences? How will you come to know that, this is going or this is getting inclined more towards ankylosing spondylitis? It is that there will be a presence of extra-articular features, like ocular features are going to be there, like cardiac features are going to be there. All right. Then in the earlier stages, there will be no neurological deficit. Ankylosing spondylitis, as the name suggests, ankylosis, it will lead to fusion of the axial skeleton over a period of time. So until and unless there is too much of the deviation from normal happened, neurological deficit is not going to be there. But in case of Pott's spine, what is happening? Neurological deficits are going to be there in earlier phases of the disease. Why? Because if there is collection of the abscess, it will result in the compression of the spinal cord and it might result in the upper motor or the lower motor neuron type of the palsy. There is a history of contact in case of Potts spine and non-structural disability. I mean, the patient is finding it difficult to bend forward, the patient is finding it difficult to get extended, while in case of ankylosing spondylitis, over a period of time, he would be developing a progressive structural disability, all right? If there is a loss of extension, for example, by 15 degrees, that is a permanent disability, because by that time, the upper part of the thoracic vertebrae has already fused. So this is a relative hint of difference in between the Potts spine and ankylosing spondylitis. Now, if you come across a question, for example, knowing about the differences in between the two, let's talk about the question that a 22-year-old male came to OPD with a complaint of progressive pain and stiffness in the side as well as on the back for the last 8 months. On detailed history, he was found to have a repeated episodes of low-grade intermittent fever and pain in back, which is more in morning. So all these features are till this point of time, it is relatively commonly shared. Now, also a history of short breathing spells. Now, this becomes an extra articular feature, but this can also be present in case of Potts spine, short breathing spells because of the pulmonary tuberculosis. On examination, his extension of back was found to be restricted and rotations of hip were found to be limited bilaterally. ESR was found to be 45 millimeter of Hg. So, as I told you that, highly unlikely that even after getting the entire question completed, you might not know that what exactly it is. It is either Potts spine or ankylosing. But how the answers or how the options are going to be changed, it will help you out in making the correct diagnosis. Now, in this case, get the ocular examination done. Yes, get the ocular examination done because there could be a possibility of uveitis, which is very commonly associated with ankylosing spondylitis. Get echocardiography done. Yes, again, because there could be a aortic valve insufficiency. There could be a third-degree heart block that the patient could be suffering from. Exercises are extremely helpful actually in the management of ankylosing spondylitis patient, and that too in the earlier stages of the disease. Methotrexate is never considered to be a drug for ankylosing spondylitis because it is not a seropositive spondyloarthropathy. The management, the treatment of ankylosing spondylitis is achieved by the non-steroidal anti-inflammatory drugs, and it is the indomethacin which is most commonly prescribed for this. All right, but the main treatment related to ankylosing spondylitis is the exercises to keep the body mobile for a longest possible duration of time, all right, in order to prevent this fusion of the vertebrae. Now, here in this case, what has happened? There is a fusion of vertebrae. Every soft tissue gets calcified, so it will appear like a bamboo, all right. The late X-ray finding for ankylosing spondylitis, it will appear like a bamboo, and there is going to be a dagger sign because when all the interspinous ligaments, they get calcified, it will appear like a dagger. So, dagger sign. So, these are late X-ray findings for ankylosing spondylitis. You obviously have to prevent. And why the examiners are asking everything related to ankylosing spondylitis repeatedly? Because they want you to diagnose this condition earlier so that you can prevent the disability or you can prevent the patient from getting permanently disabled. All right, just by doing the simple exercises. Hopefully everything is clear related to how the question proceeds. Now, how Potts spine related, TB spine related question is going to proceed. This is going to be slightly different. There will be a history of progressive pain, which will be more at night with a persistent fever, all right, and weight loss in the form of a constitutional symptoms. So, this is how it is going to be relatively different from ankylosing. Now, on examination, there is going to be a feature of neurological deficit that they will give, if at all the patient has developed any sort of neurological deficit. And typical X-ray findings, which are always going to be provided to you if they are asking anything related to the TB spine. And that is reduction in the disc space. Reduction in the disc space. It is particularly important. If examiner decides to give you a question related to TB spine and that question is going to be answered on the basis of the X-rays only, then they have to give this reduction of the disc space in that X-ray in order for you to mark the correct answer related to the tuberculosis of the spine. There is no other way, all right. Reduction in the disc space leading to angular kind of the kyphosis. All right, on this basis, you have to mark the correct answer related to this particular question. All right, as far as grades of paraplegia are concerned, it starts with from no motor power loss to some motor power loss to a motor power loss on the basis of which the patient cannot walk, and finally, the loss of bowel bladder incontinence. As far as these grades of paraplegia, progressive grades of paraplegia are concerned, or progressive neurological deficit is concerned in tuberculosis of the spine, it is very important for you to remember about the stage 4. And in this stage 4, what is happening? That there is a patient is unable to walk. There will be paraplegia inflection with severe muscle spasm. It's okay. But near complete loss of sensation and sphincter disturbances. Sphincter disturbance means that the patient is not able to feel the urination. The patient is not able to feel the defecation. The loss of urination and defecation sensations. All right. Loss of control of these sphincters is actually something which is going to be provided to you to mark the answer as a stage 4. So hopefully everything is clear. Otherwise, stage 1 will progress to stage 2, 2 will progress to stage 3. But there are specific findings in stage 4. And you know, this urinary and bladder incontinence is considered to be that specific finding. The urinary bladder and incontinence. Next, so hopefully everything is clear related to this ankylosing spondylitis and port spine related questions, how they are going to be asked. Next comes the another differential diagnosis, that is low back ache in elderly. You know, if the patient is coming in the late age groups, then there is another possibility of having low back ache. And these are the two closely related differentials. The first one is osteoporosis and the second one is multiple myeloma. Although osteoporosis is a very, very common phenomena, and multiple myeloma could be excluded from the diagnosis. It could be mixed. There is a tendency of neglecting the patient that he or she could be suffering from multiple myeloma also. So that is the reason why we are talking about these two differentials. Every time the patient tries to give you a question related to osteoporosis and backache, he is going to give you a hint of multiple myeloma in that question to rule it out. All right. Now option number 1. Both of them are going to have a progressive back pain without any history of insignificant trauma. All right. But you know, the most important clinical triad for multiple myeloma is low backache in elderly with hypercalcemia. You know, this word hypercalcemia is extremely important. And once these three features are present, it is considered that the patient is suffering from multiple myeloma until proved otherwise. All right. Until proved otherwise, the patient is said to be suffering from multiple myeloma. Now, there will be normal serological markers because it is a kind of a metabolic abnormality which is not pathological. All right, senile, age-related, primary osteoporotic abnormality where the calcium has to come to normal, vitamin has to come normal, alkaline phosphatase has to come normal. But in case multiple myeloma, there are going to be variety of disturbances because it is a plasma cell tumor. There will be hypoalbuminemia, there will be decreased reticulocyte count, all right, thrombocytopenia, anemia, and decreased albumin. So there are variety disturbances as far as serological markers are concerned. On the other hand, you know, this osteoporosis is diagnosed with T-score and Z-score. Now, this is something which you obviously are aware of, that what is T-score, all right. If you want, then quickly we can have a discussion on this. Like T-score is given as 0 to -1, it is considered to be normal. If it is -1 to -2.5, it is considered to be osteopenia. And if it is less than -2.5, then it is considered to be osteoporosis. So this is what the T-score is, where you are calculating the bone mineral density of the patient with that of a 30-year-old individual. You are comparing a bone of a patient with the normal. And there comes a T-score on the basis of which you will quantify the osteoporotic abnormality. There is another score which is known as Z-score, you know. Although no question has been asked till date related to the Z-score, but we are expecting that they can ask a question related to Z because it is for diagnosing the secondary osteoporosis. It is to make the diagnosis of secondary osteoporosis. You know, T-score is for the diagnosis of primary osteoporosis. It is diagnosed with T and Z score. So T score is basically for the diagnosis of the primary osteoporosis, while Z score is for the diagnosis of secondary osteoporosis. And this is something which we use to teach in details as far as this versions of the clinical appearances are concerned, because how to compare the bone mineral densities in between the two individuals. All right, you have to take two different other set of individuals in order to do that. Next. On the other hand, you know, these are the kind of the things which are obsolete now, like it is diagnosed by monoclonal IgG peak as well as bone marrow biopsy. Now this bone marrow biopsy will represent around 20% of the plasma cells, while peripheral blood smear will represent around 10% of the plasma cells. So this is how it is going to be relatively differentiated. All right, hopefully you will get the idea how the question will proceed, because I will give you a sample question also. Like in case of osteoporosis, there is going to be in case of osteoporosis, there are going to be multiple vertebral body collapse with decrease in the density of the bones. Now here, if you look at this osteoporotic fracture or osteoporotic X-ray, multiple of the vertebral bodies are found to be collapsed, all right, without any history of trauma, and the density of the bone is also reduced. On the other hand, in case of multiple myeloma, what is going to be there? There is going to be a lytic lesion with secondary compression, but the density is not going to be very much affected, all right. So lytic lesion with secondary compression, but the density is not going to be too much affected. So this is how the X-ray of multiple myeloma and the osteoporosis are going to be distinguished. Simply, if you see multiple fractures or multiple vertebrae to be fractured, then the answer for that question is straight away the osteoporosis, all right. As far as the treatment guidelines are concerned, you know, they are asking this question, like for osteoporosis, how to proceed. They will give you a scenario that how to proceed with this kind of a patient coming to you. Now, you divide the patient who are suffering from osteoporosis into two. One is a patient without any fragility fracture, and second is the patient with fragility fracture. What they want to ask you is that if the patient is having a fragility fracture, then what are the first line of drugs? Or these first line of drugs are same to be used in a patient without any fragility fracture. This is what they are asking. This is what they are seeking for. So, if the treatment for postmenopausal osteoporosis, where there is no fragility fracture, then simple bisphosphonates, oral bisphosphonates are to be given along with the supplements in the form of calcium and vitamin D. Alright. But on the other hand, if the patient is having a prior fragility fracture, then you start with, you know, the first line drugs are going to be parenteral bisphosphonates. So, like denosumab, the teriparatide, zoledronic acid, these are the first line of drugs to be used. Parenteral bisphosphonates are the first line of drugs to be used in case the patient is also having a fracture due to osteoporosis. That is the difference. Now, you know, there are bundles of causes for secondary osteoporosis, but today this is very prevalent. That means the patient who is having osteoporotic abnormality due to glucocorticoids. All right. Now, this glucocorticoid induced osteoporosis management is critical because, you know, apart from bisphosphonates, no other drug is considered to be a first line management. Like selective estrogen receptor modulators are not considered to be the first line of management. Here in this case, what is happening or what is considered to be the management with bisphosphonate is preferred over teriparatide, denosumab or raloxifene. All right. So this parathormone in the form of the pulse therapy is not considered to be the immediate management of choice or first line of drugs over bisphosphonates. So these are the three scenarios which the examiner can give you and convert it into a form of a question, and then they will ask you what is the first line of drugs to be used in the management of these conditions. So hopefully everything is clear related to this one. Yes, if you are attending the orthopedic OPD, then the most common complaint that you will see is that of a back pain. One set of the patient will be having back pain, and another set of patient is going to have a back pain which is radiating to lower limb. All right. You know, in NEET PG 2022 or NEET PG 2021, they have asked this question that the patient is having a heel pain. Yes, in 2022 they have asked. They've asked this question that the patient is having a heel pain. And you know, majority of the time it was marked as the answer as ankylosing spondylitis. No, they were asking a question of heel pain which is referred from the low back ache. All right. So in these type of the questions, they are going to give you the compression of either S1 or the L5 because these are the most common sites to be affected. And based on the clinical feature, they will ask you whether it is the compression of the L5 or is it the compression of S1. So in reality, you should be knowing everything related to this table on the screen of yours. But as far as this revision class is concerned, you know, this is the most important part of this table. The compression of L5 and compression of S1 because this is considered because it is most commonly observed and how they are different from each other. In case the patient is having a compression at L4, L5, all right, L4, L5 compression. So there will be a root L5 which would be compressed. And how is it going to be different from the S1? That in case of L5 compression, there will be a dorsiflexion means of the foot and toes, all right. The dorsiflexion of the foot and toes is going to be limited or it is going to be affected. While in case of S1, the plantar flexion of the foot and toes is going to be affected. This is how they are different. S1 is also responsible for innervation to this reflex, plantar reflex. All right, Achilles tendon. So reflex it can also be achieved by this S1. So this is how you are going to get the differentiations in between. and it is very important phenomena, this basic difference in between L5 and S1 compression. All right, so be ready for these kind of the questions. They are going to ask you in huge number, because you know this is the most common presentation in orthopedic OPD, and today they are asking what you see in practice. All right, now this is another differentials that we have talked about. So we have talked about the low back ache patients who could be suffering from osteoporosis, who could be suffering from multiple myeloma, who could be suffering from degenerative disorders leading to compression of the respective roots. All right, and how the process of the question will continue. You will be able to answer it accordingly. Next question, or the next differentials, are going to be the pain in hip as far as adults are concerned. So next differential is that of a hip pain in case of adults. And you know, two very important conditions, one is tuberculosis of the hip and the other one is avascular necrosis of the hip. Although both of them are going to present with a painful limp, but there is a wide variety of difference in between the two if you look very closely. And these are the differences which we are going to concentrate on in order to mark the correct answer. Now point number one, that there will be a history in weeks, 2 months. That means in case of tuberculosis of the hip joint, the history is going to be given like 4 months, 3 months, 5 months. All right, this is how the history is going to be. But in case of avascular necrosis, osteonecrosis head of the femur, there's going to be a long history, 8 months, 10 months, year, even a year. All right, so history is months to year, and pain and limping is present in both of them. All right, although limping comes first and after that the pain comes in case of osteonecrosis, but by the time you are going to assess the patient is not going to recall that phenomena. All right, he will say that I am having this pain and I am having this disturbance in walk. That is the first difference, the limitation, the time duration in between the two. Next is there is going to be associated constitutional features in case of tuberculosis, like there will be fever, there will be night cry, there is going to be weight loss, anorexia, loss of appetite, and the contact history. While in this case, in case of osteonecrosis head of the femur, the examiner will give you a specific etiology. He is going to provide the specific etiology related to the osteonecrosis. And you know, the common etiologies which the examiner can give you are, the first one, the most important one, is the alcoholism. It is very commonly observed that today alcoholic patients are gaining more and more this kind of the abnormality. Point number two is the history of allergy, you know, any skin allergy for which the patient took the treatment, and that treatment was a long-standing treatment with steroids. So basically steroid use, all right, in any form might result in osteonecrosis. And the third one is COVID, you know, because since this COVID happened, and in the COVID there was too much of the steroid given to the patient, so there are increasing incidences of this avascular necrosis head of the femur happening day by day, or we are seeing day to day. All right, in OPDs. So beware of these specific etiology will always be provided to you. Next is there will be a stage specific clinical features. In case of tuberculosis of the hip, there are going to be stage specific clinical features. Like in case of synovitis, there will be flexion, abduction, and external rotation, while in case of arthritis there is going to be flexion, adduction, and internal rotation. So this is something which we have already talked in details. I mean, there are going to be stage specific clinical features like stage 1, 2, 3, and 4 like. All right. On the other hand, in case of osteonecrosis of head of the femur, there is going to be a limitation of abduction and internal rotation of the hip. All right, and this is considered to be a cardinal. This is considered to be an important or specific clinical feature related to the osteonecrosis head of the femur. They will give you in this question that, you know, the patient when examined, they are found to have a limited abduction and internal rotation of the hip joint. On this basis, you will come to know that the patient is suffering from osteonecrosis head of the femur. And you know, the most important distinction in between the two which you have to observe while performing the question is that X-ray finding in case of tuberculosis, the reduction of hip joint, is a early phenomena. All right, while in case of osteonecrosis head of the femur, the reduction of the hip joint is a late phenomena. All right, it is not going to give, they are not going to give you the reduction, rather they will give you the flattening, they will give you the lateral migration in the form of the X-ray, they will give you increased sclerosis of the head of the femur as it is visualized over here. All right, deformed head, flattened head, but the joint spaces is still preserved. Actually, joint space is the last thing to go when the secondary osteoarthritis commences inside the hip joint. All right. So reduction of the hip joint is the last phenomena to appear in case of osteonecrosis head of the femur. You have to identify the osteonecrosis head of the femur by looking at the compression in the head of the femur. While in case of tuberculosis, you just have to identify the tuberculosis by looking at the reduction of the joint space and decreased density. These are the two differences. Now here we are having a sample question for both of them. Like first question is, a 24-year-old came to OPD with a history of limping and pain since 9 months. Details revealed that he took treatment for the skin allergy for 1 year. On examination, there is limitation of abduction and internal rotation of the left hip. ESR is 8 millimeter. What is the most likely diagnosis? So, as I told you, once you have gone through all those things that we have already talked about, you will specifically mark the answer as osteonecrosis head of the femur. Possibly, he is suffering from osteonecrosis head of the femur. On the other hand, there is another question like 25-year-old female HIV positive on antiretroviral drugs. Now, the patient is HIV positive. He is on antiretroviral drug. Antiretroviral drugs also result in osteonecrosis. But you know, if you read the question, that came to OPD with the complaint of progressive pain and limping for the last 5 months. On examination, right thigh is kept in abduction, external rotation with the apparent lengthening of the affected limb. That means these are the stages of synovitis in case of tuberculosis of the hip joint. And the answer goes in the direction of TB hip. Then one thing that you can get confused with, that you know, if there is a etiology provided that the patient is HIV positive and the patient is suffering and his patient is on antiretroviral drugs, then why is it not osteonecrosis? Because if the patient is HIV positive, the patient is immunocompromised, and you know, tuberculosis is a phenomena which happens in case of immunocompromised individuals. So this etiology holds true. This etiology is consistent or goes consistent with tuberculosis of the hip joint also. Alright. So as far as the differentials related to the hip pain in adults are concerned, hope everything is clear and you will be able to mark the correct answer. You will come out with the correct answer for tuberculosis and avascular necrosis head of the femur. Next is the differential of the hip pain in case of children. You know, there are conditions with which a child can be presented to you with the hip pain, and how the examiner will try to portray this question by keeping these two differentials. One is Leclerc-Perthes disease and the other one is slip capitofemoral epiphysis. You know what happens in Perthes disease? The age, specifically they are going to give you the age group of around 4 to 8 years. Alright. You know why we are talking about this? Because as I told you in the beginning also, that we are dealing with this phenomena because examiner wants you to identify the disease which are non-repeated. I mean, these are the kind of the conditions which, if at all asked, it will be asked for the first time and you have to mark the correct answer. So these are the things in this revision program that we are focusing on, that are not on the basis of day-to-day or the regular revisions you are going across. Alright. In case of Perthes disease, the age will always be mentioned in between 4 to 8 years of age. While in case of slip capitofemoral epiphysis, it is a phenomena to be happening in pre-adolescent age group, alright, or early adolescent age group. That is 11 to 14 years of age. That will be the first difference in between the two, alright. So how the question will proceed? A child coming with a pain in the right hip and the age will be mentioned. So just on the basis of the age, you will get attended that whether it is about Perthes or SCFE, the examiner is asking. Next is, you know, stereotypical picture of the child will be provided. Like the patient will be extremely thin built, overactive, disturbing kind of a child, as if he is suffering from ADHD, attention deficit hyperkinetic disorder. These are the things they used to give or they can give, all right, for the assistance of your question. On the other hand, the patient who is suffering from SCFE would be provided with the hint of obese or a hypogonadal male, all right, obese or a hypogonadal individual. Now, pain and limping is a long history. Long history means it is going to be history in several months. Months means around 8 months to 1 year. Alright, 8 months to 1 year. This is going to be a long history which will be provided to you. But in case of SCFE, it is going to be the history in weeks. Alright, history in weeks like 6 weeks. Alright, it will be a history which is provided to you in the form of the weeks. And as far as the limitation means, one of the clinical feature on the basis of which you will confirm your diagnosis is that there will be limitation of abduction and internal rotation of the thigh or in case of Perthes disease, while there will be increased extension of the hip joint observed in case of slip capitofemoral epiphysis. So how the question will proceed, like if I give you one example, that mother came with a complaint of limping observed by the child. Age was 7 years. He is suffering from ADHD. On examination, there was limitation of abduction and internal rotation. What is the most likely diagnosis? Answer for that question goes in the favor of Perthes. Another question is, a 13-year-old male having 86 kg weight is complaining of progressive pain and limping for the last 1 month. On examination, the extension of the hip joint was found to be increased in comparison to the normal. What is the most likely diagnosis? So this is how the examination question goes. All right. So as far as this Perthes disease is concerned, what you are going to observe in the X-rays, that the head of the femur is, the head of the femur is collapsed on the affected side. While in case of SCFE, it is the displacement of the neck in relation to the head. This is how it is going to be differentiated. When you see a head collapse in the X-ray of a child head of the femur, answer for that question is Perthes disease. Hopefully everything is clear related to this. Means they will ask you this question, and on the basis of that you have to mark the correct answer. Next question is relatively simpler, but it is relatively commoner. A 7-year-old male came to OPD with a complaint of pain in right hip, limping for the last 7 days. Now, how is it different from the previous two? In case of Perthes, long history. In case of SCFE, intermediate history, 6 weeks to 2 months. But here we are having a history of just 7 days. On examination, there was limb which was kept in abduction and external rotation, all right, with the apparent lengthening of the limb. So nothing, actually it is the stage of synovitis, which could or could not be due to any reason. So here what the patient is having is the hip synovitis. The patient is having hip synovitis. Now this hip synovitis could be because of or couldn't be because of any reason. That means it could be non-specific synovitis, it could be tubercular synovitis, it could be infective synovitis, it could be reactionary synovitis, it could be irritable synovitis, so anything. But the stage the patient is presenting with is the acute synovitis of the hip. That means collection of the fluid inside the hip joint. Now, how will you proceed with? The proceedings requires, will you go for the MRI immediately? Obviously not. As I told you repeatedly, I am saying this, that don't mark this answer if it is provided to you in the question, until and unless there is a mandatory indication provided. Next, rest, NSAIDs and observe. We will come to this option again. Start anti-tubercular drugs. You see, at this point of time, you are not aware that the patient could be suffering from ATT, from tuberculosis. So wait for some duration. Get him properly investigated. Now continue weight bearing walk. If you ask the patient to walk continuously, then this stage of synovitis is extremely painful and it might result in the arthritic stage. So basically ask the patient to take rest, put the patient on non-steroidal anti-inflammatory drugs, and then observe the patient. There is a possibility that if it is without any reason, if it is non-specific, then the patient will come out cured. If it is because of a reason, then you have to search for that reason. So you have to observe the patient, and that is the reason why this condition, non-specific synovitis, is also called by the name of observation hip, because you have to observe for the secondary complications. So answer for this question is rest, non-steroidal anti-inflammatory drugs. Some of the surgeons, they are preferring the application of the traction, but that traction application is now having no advantage. All right. And finally, observe. So this is actually more common, the condition, out of the 3 differentials that we have talked about. The first one is Perthes, the second one we have talked about was the SCFE, and the third one is this transient synovitis, and this is very commonly observed. Next question, next clinical scenario, which you already are aware of. I mean, so many times they have asked this question, and one confusion, there is only one point of confusion that is needed to be eliminated. A mother of a 6-year-old child came with the complaint of a 3-year-old child came with the observation of having an abnormal gait. On examination, she had a genu valgum. All right, she had this genu valgum, and with intermallular distance of 6 centimeters, with wrist widening and prominent abdomen. Serological markers revealed 1243, that means alkaline phosphatase is increased and the calcium concentration is decreased. That means calcium concentration is kept normal, that is 9.8 milligram per deciliter. So it is normally kept. What is the diagnosis with which the patient is suffering from? So answer is straightforward. Answer for that question is clearly the rickets. You see it in the X-rays also. You are aware that what you see in the X-rays, in the X-ray, you observe the depression, that means cupping of the metaphysis. You observe the abnormalities in the end of the metaphysis, that is fraying, and you observe the increase in the surface area, that means splaying of the metaphysis. So all on these basis, the answer is certain, that is that the patient could be suffering from rickets. Next is all right, sorry. So no, you see, the mother. So why is it? First of all, why is it rickets? You know, despite having the patient is having a normal calcium concentration in the blood, why is it considered to be rickets? It is considered to be rickets because of the because the calcium is compensated by increased parathormone. You know, osteogenesis imperfecta is something which you already know that it is going to be a blue sclera will be there, callus formation will be there, all the other features are going to be presented. Arthrogryposis multiplex congenita, multiple joints are going to be fused with the abnormalities in the movement. Achondroplasia is a dwarfism which is having disproportionate kind of a limb length. So all these things are not what this kind of a question is presented with. So answer for this question is straightforward, that is rickets. Remember, if the examiner is giving you a raised alkaline phosphatase and increased normal calcium ionic concentration, answer for this question is rickets always. All right, hope everything is clear related to that particular question or the topic. Next are the intrinsic muscles of the hand. You know, one question at least is going to be out of this topic, like they will ask about this car test, book test, from and sign and all. So just let's have a discussion on how this proceeds. All right, that how will it proceed further immediately or quickly, because it has to be related to the anatomical perspective. Until and unless we don't relate it with the anatomy, you won't be able to find it that what exactly is happening in it. Just try to understand. Actually, the thinner muscles of the muscles of the hand are divided into 5 different groups. The first group is the thenar group, the second group is the hypothenar group, then the third one is the lumbrical, and the fourth one are the interossei. All right, all you have to remember are the names of these thenar muscles, like the flexor pollicis, abductor pollicis, opponens and adductor pollicis are the muscles in the thenar group. So whatever the name of these thenar muscle is, they are representing the similar actions also. While in the hypothenar group, we are having flexor digiti, abductor digiti, opponens digiti and palmaris brevis. As far as the names of the lumbricals are concerned, it is not a named muscle. They are just numbered muscle. Numbered muscle like 2 medial, 2 lateral. You are dividing it into 2. Similarly, even the interossei are just numbered muscle, like they are adduction of fingers and abduction, the palmar interossei and the dorsal interossei. So these are the muscles in each group. Now the functions of interossei is that the palmar interossei is responsible for adduction, dorsal interossei is responsible for abduction. Flexor muscles of the thumb will lead to flexion. All right, it might lead to abduction, the abductor will lead to abduction. Extension of the thumb is because of the extensor pollicis, and opposition of the thumb is because of the opponens pollicis. So these are the functions of the thenar muscles. As far as the function of lumbricals are concerned, it is responsible for flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. This is the function of lumbricals. All right. Now what happens? The nerve supply. Only thing remains is the nerve supply, that how these muscles are supplied by the nerve. You know, the flexor surface of the forearm and hand predominantly goes under the supply of median and ulnar. And you know, the lateral part predominantly is under the median, medial part is predominantly is under the ulnar. So the 4 thenar muscles, out of 4 thenar muscles, because the thenar is present laterally, the first 3 thenar muscles are supplied by the median. The only thenar, that is adductor pollicis, is supplied by ulnar. All right. All the hypothenar muscles, because it is medially arranged, all of them are supplied by ulnar. All right. As far as the interossei are concerned, the 4 palmar interossei and 4 dorsal interossei. So all 4 palmar interossei which are responsible for adduction of the fingers and all 4 dorsal interossei, all of them are supplied by the ulnar nerve, all of them. So what you are left with is the lumbricals. Lumbricals, basically the 2 medial are supplied by the ulnar. 2 medial are supplied by the ulnar and 2 lateral are supplied by the median. So with this we have covered about the nerve functions also. Once this nerve supply is concerned, so at this point of time you are aware of the muscles, their action and their nerve supply. Now it will become easier for you to understand that what goes in these individual tests. Like in case of a card test, imagine the examiner is asking you to hold a card in between the two fingers and is asking to pull it forward. If you have applied a resistance, that means your palmar interossea is normal. So it is not like that card test is related to ulnar. Now the examiner is going to ask you that what you do in card test. What is the name of the muscle? What is the name of the function that you are testing in card test? So basically card test, you are testing the palmar interossea. Alright. And this card test is the assessment of the ulnar nerve, because all palmar interossea are supplied by the ulnar nerve. Now the book test is that you ask a patient to hold the book by adduction of the thumb, and you know adductor pollicis brevis is not supplied by median, it is supplied by ulnar. So if the patient is not able to hold the book properly, you can easily pull this book out. That means adductor function of the thumb is lost. So what you are testing in book test is the thumb adduction. You are testing for thumb adduction. And what is happening in this book test? It is the testing of the ulnar nerve again. Alright. Froment sign is simply a modification of the book test. Like if you are asking a patient to hold a book, he is not able to perform that book test, so he will hold the book tightly by flexion of the thumb. And that flexion of the thumb is the function of the flexor pollicis longus muscle, which is supplied by median. Alright. So froment is again a test for the ulnar nerve. So it is actually the modification of the book test that the patient performs. Pointing index, you know that both flexor digitorum profundus and flexor digitorum superficialis tendon to this index finger is under the supply of median. Rest, there is a sharing of ulnar and median by in the rest of the other three. So if there is an injury to both median as well as ulnar, if there is an injury to the median nerve, then all the fingers will get flexed when you are asking a patient to form the fist. One finger remains pointing, and that is known as pointing index. So hopefully this point is also clear. Next is ape thumb deformity. You already know one of the movement of the thumb, that is adduction, is not under the control of median. So if there is a median nerve injury, then all the muscles will be paralyzed except adductor. So it will go into adduction, leading to ape thumb deformity. Alright, this is how the ape thumb deformity will look like. So it is again a feature of a median nerve. So both pointing index as well as ape thumb deformity are the features of median nerve. At least one question they are going to ask you out of this topic. Like pen test. You know, abduction of the thumb is a function of abductor pollicis muscle, which is supplied by median. So ask a patient to touch the pen by abduction. If he is not able to do so, that is pen test positive. So pen test, what you are testing is abduction of thumb. Alright. In pen test, you are testing the abduction of the thumb, and this is the test for the median nerve injury. Alright. Next, claw hand. You already know what the clawing is. There is extension of the metacarpophalangeal and flexion of interphalangeal joint, and it is predominantly the result of the ulnar nerve injury. Alright. This claw hand is also known as intrinsic minus deformity. So this is something which you have to practice again and again, because as I am saying repeatedly that at least one question they are going to ask straight away from this kind of the questions, from this kind of the topic. You know, nerve injury related topic. And now the question is not going to be a one-liner. They are actually asking you the correct demonstration of these nerve injuries. Alright. Now, what is Tinel sign? Next question. Yes, because this is a considerable practical question. If at all they ask you anything related to this question, it will be first time asked question. Alright. Tinel sign. What is Tinel sign? Or which of the following is incorrect related to the Tinel sign? So first of all, let's talk about what is Tinel sign. Just try to understand. Imagine there is an injury to any nerve. Let's take an example. I'm saying that there is an injury to the radial nerve. Alright. There is an injury to the radial nerve. As a result of which there are several abnormalities in the sensations. There are abnormalities in the motor movement. When the patient comes to you, you start tapping along the course of the radial nerve on the skin. And the moment when you reach the point where the radial nerve is broken, then the abnormal sensations are felt in the area of distribution. Alright. Abnormal sensations are not felt over where you are tapping. It is felt at the area of distribution. You have marked that area. Alright. With the bony prominence, you have marked it. You have related it. Like it could be, for example, 15 centimeter above the level of radial styloid. And you have asked the patient to come after some duration of time. The patient is revisiting you. You have started doing the Tinel sign again. And this time, on tapping just 10 centimeters above the level of radial styloid, you are able to feel the abnormal sensations. What does it indicate? Indeed, it indicates that the radial nerve is the nerve after getting injured is getting regenerated. Alright, there is a regeneration of the nerve because you are observing a progressive Tinel sign. So this is what the Tinel sign is. So it is a clinical test. Point number 1, it is a clinical test. Yes, it is a clinical test. It means tunnel sign is not something observed on the x-rays. Point number 2, to demonstrate the recovery of the nerve. Yes, it is used for the demonstration of the recovery of the nerve. I mean, tunnel sign you are not going to perform in order to know that the nerve is injured. The nerve injury is going to be demonstrated by simply loss of movement or the abnormal sensations. It is used to demonstrate whether the nerve is getting recovered or not. Point number 3, nerve is tapped along the course of the nerve from distal to proximal. Yes, because there are two ways of tapping the skin course of the nerve. One is proximal to distal, other one is distal to proximal. So you always have to go from the distal to the proximal end. And point number 3, abnormal sensations are felt at the site of nerve lesion. No, as I told you, abnormal sensations are going to be felt in the area of distribution of that nerve. So this is the answer of this question. And tunnel sign, as I am repeating again, it is going to be very important. I mean, if at all they ask this question, it will be for the first time asked question, tunnel sign, because it is a practical question. It is performed in day-to-day basis as far as OPDs are concerned. Next, the question is related to dequervantinosynovitis. Now, you know, this is a kind of the question which we were teaching with the hope that they are going to ask, and they have successfully asked this question 2 times in 2019, 2020, because of the same reason, you know, confusing options. The two tendons which are getting impinged in the first column of the extensor compartment are abductor pollicis longus and extensor pollicis brevis. As a result of which, particularly more common in female patients, they are going to observe the pain at the radial styloid, and once you perform the test, that is Finkelstein test, a provocative test to the patient, then the condition is going to be too painful for the patient to handle. Alright, so dequervantinosynovitis is the question. And the two tendons which are observed to be affected, which are observed to be compressed under this, are abductor pollicis longus and extensor pollicis brevis. So that is the correct answer for this question. As far as the name of the test to demonstrate this dequervantinosynovitis is, it is Finkelstein test. It is Finkelstein test. And you know, Finkelstein is a provocative test. I mean, when you perform this test on a patient, all right, be careful. You have to ask the patient whether you are going to bear the pain out of it or not. Otherwise, she is going to curse you. All right. Next, another very key kind of the presentations are lateral epicondylitis and the carpal tunnel syndrome. You know what happens in lateral epicondylitis is that if there is a pain over here, when there is a tenderness over here, and this is lateral epicondylitis, what you have to be aware of is the name of the test. The name of the test is just Cousin test. All right. And what is Cousin test? You ask a patient to perform the wrist extension, all right, against resistance. This is going to be painful at the site of lateral epicondyle. So this is known as Cousin test positivity for lateral epicondylitis. As far as carpal tunnel syndrome is concerned, Fallon test. You know everything related to carpal tunnel. You know, we have talked so many times about carpal tunnel. We expect that you know everything related to carpal tunnel syndrome, and that is the reason we are not wasting our time by putting it inside the rapid revision kind of a class. All right. Fallon sign, when you flex both the wrist and apply resistance to each other, there will be further compression of this nerve, leading to abnormal sensations, more abnormal sensations. That is Fallon test positivity. So tourniquet test, manual compression, all these things can also be achieved. Even tunnel sign positive in case of this median nerve compression of the carpal tunnel syndrome. All right. As I told you in the before also, that this is a kind of a condition which is again very, very commonly observed. Like a 28-year-old police trainee come to OPD with a complaint of pain and swelling in the left foot for the last 1 month. You see what is happening over here, a police trainee. Every time you get a question, orthopedic question, where the profession related to athleticism or overuse of the bone is given, then always think about a stress fracture. That, you know, it is because of the stress to the bone that the bone is now giving away. The bone is getting fractured. And police trainee, army recruits, long dash runners or the long race runner, marathon runner, the jumpers, these are the kind of the professions which are going to be provided to you in this question. Now, with a complaint of pain and swelling in the left foot for the last 1 month, so there is a long history of pain. On examination, there was no crepitus found, although when you think of a fracture, you will try to move it, but there is no crepitus which is found. X-rays were also revealing no fracture. But have you ruled out the diagnosis that it is not a stress fracture? No. Why are you not ruling it out? Because, you know, the cortex is not broken. It is the break which has started to happen at the medullary level. The cortex is not yet encroached, but it is considered to be a stress fracture which requires rest and immobilization. So what next? Continue training? Obviously not, because now you know that the development of the fracture has already started, but it is not extended up to the level of the cortex. You will ask the patient to take rest. Warm fomentation will further initiate the inflammatory process, and it is going to be more painful with more swelling eventually. Immobilization and non-steroidal anti-inflammatory drug is considered to be the best management, because it is related to the mobility, it is related to the overuse. What is the treatment? Immobilization. All right, rest is the treatment. CT scan, obviously, because you already are aware, you have made the diagnosis, you further need not to confirm your diagnosis, although CT scan is not going to help you with the diagnosis. It is rather the MRI which might reveal these stress fractures. All right, because medullary canal breakdowns are going to be available on the MRI, not the CT scans. So although you will not do the MRI immediately for the patient, you will ask the patient to take rest, come after 1 week. Obviously the patient will say, now I'm much better, and you will ask him to continue this for the period of around 1.5 months. Hopefully everything is clear related to this basic question which you see in day-to-day practice. Next is 55-year-old diabetic male came to, but again a very, very important and a conceptual question. This is the kind of the question on the basis of which, this is a kind of a topic on the basis of which you can save the patient's life by not performing the amputations which are unnecessarily triggered. Just try to understand. 55-year-old diabetic male, a patient who is a diabetic, all right, came to OPD with a complaint of pain, swelling, tenderness over the lateral aspect of the right ankle. Now the skin discoloration is also present with limitation of dorsiflexion. The patient is not able to dorsiflex the ankle, and inversion of the foot. Dorsalis pedis is not palpable. What are the problems? The problem is that the patient is having a common peroneal nerve palsy, sort of, because the dorsiflexion inversion is the function of the tibialis anterior muscle. It is found to be affected. Next, the patient is we are not having a dorsalis pedis which is palpable. So which of the following is incorrect? All right, for the structures for the question which is provided to you. First of all, the patient who is suffering from the condition, first of all, you know the condition. The name of the condition is neuropathic joint disease. Neuropathic joint disease, also known by the name of Charcot joint disease. You know what happens in this neuropathic or the Charcot arthropathy, where the patient loses over a period of time the proprioception as well as the joint sensations. When there is a loss of proprioception, when there is a loss of joint sensation, the patient is not going to this kind of ankle is subjected to repeated injuries, and because of this repetition of injuries, there is going to be a secondary osteoarthritis developed. All right, so options, if we go option wise, the first option is that repeated injuries are common. Yes, obviously the repeated injuries are common because the protective pathways are lost. Appropriate footwear will obviously help you in order to contain the foot within the confines of an appropriate footwear. All right, it is always helpful. Next, strict diabetic control with anticoagulant is considered to be the management for this condition, because the diabetes is a provocative event. All right, the diabetes is responsible for increasing this this neuropathic joint condition. So strict diabetic control is required. And point number 4, is it a Berger disease? Obviously not. So this is not the Berger disease we are talking about. In Berger disease, the features are going to be different. In Berger disease, there will be thinning of the foot, there will be loss of shine of the foot is going to have a loss of hair, dorsalis pedis and the posterior tibial arteries are going to be not palpable, and there will be a set of gangrene which could be given, and a history of smoking, obviously. So the Berger disease is entirely different from what is being witnessed over here. We are talking about a neuropathic joint disease, Charcot arthropathy, because of the loss of proprioceptive and pain pathways. All right, hope everything is clear related to this topic. If at all this question is asked, then you have to help me, you have to thank me for the same reason, because this is for the first time. If they will ask this question, then it is going to be the first time asked question. All right, that which of the following is against the principle of tendon transfer. First of all, try to understand what the tendon transfer is. Imagine if the patient has lost the activity of one of the tendon because of the nerve injuries or because of the nerve supply, then what? Then if there is a loss of the nerve injury or the nerve supply, then what it will lead to? The patient won't be able to move that structure. So which of the following is incorrect related to the tendon transfer? This is what we are tasked. Now, what is tendon transfer? That you take another working tendon and insert it at the site of a tendon which is lost. All right. So we are talking about the principles. The option number 1, that the donor tendon should be synergistic. You know, both these two tendons should have at least one action synergistic to each other. Like if you are, for example, will be taking the example of a tibialis anterior loss to be achieved by tibialis posterior transfer. All right. Now, tibialis anterior is a dorsiflexor, tibialis posterior is a plantar flexor, but both these two tendons have one common action, that is inversion of the foot. All right. So both the actions should be synergistic, the tendon which you are transferring. Second, the muscle power of the tendon to be transferred should have the minimum power of 3/5, and that actually is the answer for this question, that it is not correct. Actually, the minimum power should be 4/5. You know, just try to understand. Power 5/5 means full resistance. Okay, start with the 0. Power 0/5 means no movement. Power 1/5 means flickering movement. Power 2/5 is against, if the gravity is eliminated, then the movement is happening. 3/5 is against gravity but no resistance. 4/5 is against gravity with some resistance. 5/5 is against maximum resistance. All right. So if the power is 4/5, it means that the patient is able to move it against gravity and we apply some resistance also, then it can be felt. That is 4/5. Now, in order to transfer this tendon, you have to erase it from the origin. When you erase it from the origin and reapply it, reattach it, then you are losing a power by 1. That means the effective power of the transferred tendon will be left as 3/5. It means that the transferred tendon will be acting against gravity, but you know, against resistance it is not possible. Then what is the role of transferring a tendon which is having a power 2/5, left power 2/5, because it cannot act against the gravity. So that tendon transfer is going to be a failure. All right. So what should be the minimum power of the tendon to be transferred? It should be at least 4/5. 5/5 is best. Then joint should be passively mobile. Obviously, if the joint is adhered, if the joint is ankylosed, what is the point of putting the tendon transfer? Because you cannot achieve any mobility at a fused joint. So this is the primary requirement, that the joint has to be passively mobile at the around which you are transferring the tendons. Then tendon should be rooted subcutaneously in order to prevent the adhesions and the contractures later in the course of disease or after performing this procedure. It has to be rooted. It should be like that. It should be rooted subcutaneously and it should be sharing a similar inclination, like a vertical tendon to be transferred by a vertical tendon. A horizontal tendon has to be transferred by a horizontal tendon. So these are the principles of tendon transfer. We are expecting this question to be kept in your examination in future, because you should be knowing at least about the basic principles of the basic topics like this. Again, I'm revealing it that if you get these kind of the questions, then you have to realize that in coming years, 24, 25, these are going to be your major questions. Like supratrochanteric shortening of the limb is demonstrated by all of the following except. So basically, these are the questions which are related to the examination of the hip joint. And now the things are getting changed into more practical evaluation. And these are going to be your questions in your examination. That supratrochanteric shortening of the limb is going to be demonstrated by all except. So first of all, try to understand what do you mean by the term supratrochanteric shortening. Just try to understand this. Imagine this is the acetabulum and this is the hip joint. All right. Now, there are a variety of conditions which might affect the hip, right? From infection, septic arthritis, tuberculosis, avascular necrosis, osteonecrosis, even the trauma, secondary osteoarthritis. There are wide variety of conditions which might affect the hip joint. What will eventually happen is that the height of the head of the femur is going to be depressed. Over a period of time, there will be disintegration, degeneration of the head of the femur, as a result of which this space, that means the space in front of the trochanter or proximal to the trochanter, will be reduced. All right, because of proximal migration of the greater trochanter. So this is what known as supratrochanteric shortening of the femur, because when you measure the length of the lower limb, it is measured from the ASIS up to the medial malleolus. All right, and when there is a supratrochanteric shortening, then the length of the lower limb is going to be affected. Now you have to specify whether this shortening is happening at the level of trochanter, above the level of trochanter, below the level of trochanter, at the level of knee, likewise. So for supratrochanteric shortening, these are the tests, but there is one exception in this, and this is what the examiner is asking for. All right. First of all, shoemaker line. For the first time we are getting introduced in this sessions, like what is shoemaker line? Just try to understand. This is the normal hip joint. All right. You take a point from ASIS. You take a point from the GT, that means greater tuberosity, greater trochanter, tip of the greater trochanter, and ASIS. All right, and you project both these two lines proximally. You project both these two lines proximally onto the abdomen. Now, where they will intersect? Exactly in the center and above the level of umbilicus. Now, you take another example, all right, where there is a discrepancy, like this is the GT and this is ASIS, which is on the normal side. This is ASIS, but the GT is there on the abnormal side. It is slightly proximal. Now, you draw a line which is connecting both these two and project proximally. Now, this time we are not going to have this intersection exactly in the center. It will rather be at the other side of the abdomen. So, this is known as shoemaker line test positivity. Now, if there is an intersection happening on the left side of the abdomen, then the right-sided supratrochanteric shortening is present. That is what the shoemaker line is. Next is Nelleton's line. Now, in this Nelleton line, what is happening? There is a point that is ASIS and ischial tuberosity. You draw a connecting line in between the two, ASIS and ischial tuberosity. All right. You connect both these two. Normally, what happens? The GT, the greater trochanter, is below the level of this line. But what will happen in supratrochanteric shortening? There will be a proximal migration and the line will pass through this greater trochanter. So, this is also suggestive of, Nelleton's line is also suggestive of supratrochanteric shortening. Then is the Bryant triangle. Now, Bryant triangle, the three lines are to be constructed. One of the line is dropped from the ASIS. You know, if you drop a line from ASIS down on bed. Second is a line which is connecting the ASIS and tip of the greater trochanter. All right. And the third is the line connecting the perpendicular. So, we are left with three different lines. One is the hypotenuse, then second is the perpendicular, and the third one is the base. And you measure the centimeters of the base. You measure this base in centimeter. For example, the patient is having a right-sided supratrochanteric shortening because of any reason. The left-sided base is found to be 4 centimeters if it is given in the example, and the right-sided base is 2.5 centimeter. It means the patient is having a supratrochanteric shortening of 1.5 centimeter. So, these are the three tests, these are the three signs which are going to represent the supratrochanteric shortening in the femur. Now, if you go back to the example, back to the question, that supratrochanteric shortening is demonstrated by all except, so Shoemaker, Nelleton, Bryant, all of them are these. Treathoven line is the answer for this question. Actually, Treathoven line is for slip capitofemoral epiphysis, where the line is projected from the lateral border of the neck and is projected proximally. If it is passing the acetabulum, it is normal. If it is not passing the acetabulum, it is SCFE. So, this Treathoven line is not the answer for this question. All right. But it is important for you to know about Shoemaker line. It is important for you to know about Nelleton line and the Bryant triangle. There is another way of demonstrating this this angle or the supratrochanteric shortening, and that way is the Sheen's parallelogram, Chine, the Sheen's parallelogram. Now, what the Sheen's parallelogram is, actually you draw two parallel lines, one touching the two ASIS, second touching the two tip of the greater trochanter. If the difference in between, you know, both these two have to be parallel in normal individual. But in case if one patient is having a supratrochanteric shortening, then these two lines will converge, all right, at the supratrochanteric site where there is a shortening. All right. So, this is another way of knowing about the supratrochanteric shortenings in the femur. Remember, today this question could have, or this question seems to be insignificant, irrelevant. But remember, there is a possibility that they might ask this question in this examination also. But yes, in 2024, 25, 26, certainly you are going to be loaded with these kind of the questions. All right. Hip stability is tested by all except, next question is that all of the following are the tests to demonstrate the stability of the hip joint except. So, what are those exceptions? So, first of all, Trendelenburg test, yes, it is for the demonstration of the hip stability. Telescopy test, you know, it is also for the demonstration of the hip stability. Active SLR, you ask a patient to perform this active SLR. Until and unless the hip joint is stable, he cannot perform it. So, what you are left with, Thomas test. Thomas test obviously is for the fixed flexion deformity of the hip joint. It is not for the assessment of the stability of the hip. All right. So, what is Thomas test basically? Basically, this image is going to represent everything about or everything in relation to this Thomas test. So, what exactly is Thomas test, or what exactly or basically is Thomas test is that, you know, it is the reappearance of, that means unmasking of the fixed flexion deformity by obliteration of exaggerated lumbar lordosis. All right. So, this is fixed flexion deformity of the hip. Thomas test is basically for the demonstration of the fixed flexion deformity deformity of the hip joint. All right. For the demonstration of the fixed flexion deformity of the hip joint, we are performing this Thomas test. All right, by unmasking of the fixed flexion deformity by obliteration of exaggerated lumbar lordosis. At least this point you need to remember as far as this question is concerned. You know, this is one question which again I am saying that they are going to ask this question related to Trendelenburg again and again. Now before we talk about this question, let's have an example how this Trendelenburg works normally. First of all, you see, as a human or as an individual, this is, imagine your trunk, this is the umbilicus and this is the hip joint. All right. Now, when you are made to bear weight on one lower limb, then what will happen? These muscles will contract and they will try to incline the other side of the pelvis towards the weight bearing lower limb, so that the center of gravity shifts towards the weight bearing lower limb, and this will give you a stable stance. All right. So in this process, throughout this process, there is a abductor mechanism functional of the weight bearing lower limb, which is trying to pull the other side of the pelvis up to get it inclined towards the weight bearing axis of the limb. Throughout this process, what is happening, that the other side of the pelvis, you know, it is tilted up towards the body, towards the weight bearing limb. But imagine if there is any defect in any of the components of this abductor mechanism, all right, like gluteus medius or minimus are paralyzed, like there is a malunion which is happening in the greater trochanter up to the neck of femur, head of femur, or there is a dislocation, neglected one, all these things, if it is present, any abnormality in the entire lever arm, all right, of the hip joint abductor mechanism, then what will happen? When you bear weight on this limb, then it is ineffective to pull the other side of the pelvis, as a result of which the other side of the pelvis will be dropped down under the influence of the gravity, and that is what the Trendelenburg test positivity is. All right. So now if you look at this question, although it's a huge topic, this is not the class to have a discussion on the Trendelenburg test. It is a topic which will require the understanding at least for 35 to 1 hour, 50 to 1 hour duration, 50 minutes to 1 hour duration. But what you need to remember under this Trendelenburg is that certainly there is nothing which you have to mug it up in order to mark the correct answer. Until and unless you are covered with the basics, you won't be able to reach the correct answer. You have to mark the correct answer based on what the knowledge, what the basics or background are related to Trendelenburg that you have. All right. So you have to believe in yourself in order to mark the correct answer related to Trendelenburg. If you don't know anything related to Trendelenburg, basically you have to leave the question, all right, in that scenario, because when you mug something up and mark the answer related to this topic, it is obviously not the correct answer that you are marking. Now 35-year-old came with the difficulty in walking upstairs. That is the difficulty that the patient could be having. When he was made to stand on the right lower limb, the left sided pelvis dropped down. That means left side of the pelvis dropped down. Now at this point of time, you have to decide that which side is affected first of all. Is it the right or the left side is affected? Standing on the left lower limb, the right side had moved up. That means when he was made to bear on the right lower limb, the left side of the pelvis dropped down. That means it is the failure of the abductor mechanism on the right side, that it is not able to lift the left sided pelvis or get it inclined towards the weight bearing surface. So problem number one, that the patient is having a right sided abnormality. All right, and you know the components of the abductor mechanisms are the gluteus medius and minimus, and gluteus medius and minimus are supplied by the superior gluteal nerve. That means the patient is having the abnormality in the right sided superior gluteal nerve palsy. Again, I am repeating my sentence or the statement that Trendelenburg test is something which requires too much of understanding. If you are not having that, then don't mug it up and mark the answer. It requires the basic understanding, and then only you would be able to come up with the correct answers. In future, this is considered to be the entry level question. First of all, the side determination is very important. The components of the abductor mechanisms are important. And to some extent, you came to know that where exactly the Trendelenburg is going to be positive or negative. All right. As far as the abnormal gaits and the reasons for those abnormal gaits are concerned, these are the hand to knee gait is the result of the quadriceps weakness. You know, if the patient is having a quadriceps weakness, you won't be able to extend the knee while weight bearing. So the knee will be thrusted into flexion, and that flexion thrust is going to be prevented by the placement of the hand by the patient. Keep it extended and complete the stance phase of the gait. So hand to knee gait is because of the quadriceps weakness. Extensor lurch is because of the gluteus maximus palsy, because the patient is not every time the patient bear weight on the affected limb, that because of the failure of this gluteus maximus, there is a forward flexion. All right. So in order to prevent it, there is exaggerated lumbar lordosis every time the patient bear weight on the affected limb. So that is known as extensor lurch. Trendelenburg gait, just now you came to know it is because of the gluteus medius palsy, the muscles which are involved, although there are other reasons also. Then is the high stepping gait. It is known as the gait because of tibialis anterior palsy, common peroneal nerve injury, because in case the patient is having a foot drop, he has to take a higher stance, he has to take a higher clearance of the ground in order not to rub the dorsal surface of the foot on the ground, all right, in order to prevent the frictional injury. So that is high stepping gait because of tibialis anterior palsy. And the short stance is obviously the antalgic gait. That means you decrease the duration of the stance, you decrease the duration of the weight bearing on the affected limb when there is any painful condition happening right from foot up to the level of the hip joint. All right, you decrease the duration of that weight bearing. So every time you bear weight on the affected limb, immediately you have to shift it to the normal. So that is short stance gait, which is considered to be the antalgic gait or the painful condition or the painful limb. Next comes about the tumors. As far as the tumors are concerned, today the most commonly asked tumor is always the GCT. Now, as far as this GCT is concerned, 3 to 4 lines you have to remember, and here it means this is something as a topic which you cannot evade, you cannot escape. The only thing how to identify a epiphyseal tumor is related to the growth plates. If the tumor is epiphyseal and the growth plates are visible, it is chondroblastoma. It is simply the chondroblastoma. And if this epiphyseal tumor and the growth plates are found to be obliterated, it is giant cell tumor or the osteoclastoma. Simple. So epiphyseal tumor, growth plate look for. You have to look for the growth plate. If it is visible, chondroblastoma. If it is obliterated, answer is GCT. Simple. All right. Now GCT related several of the facts that you have to remember. All right. You have to go into the details of having a basic understanding. At least what is a palpable finding? Eggshell crackling on palpation, aggressive benign tumor which can be converted into malignancy. What are the possibilities? 5%. 3% are the possibilities for metastasis by a benign tumor also. 3% are the possibilities. And that too upper limb GCT, like not the lower limb GCT will metastasize. It is the upper limb GCT that has got the tendency of metastasizing. So these are the things you should not evade. I mean, GCT is something, chondroblastoma is something that you have to be ready with when you are sitting in the examination. Osteosarcoma related, everything which is related to osteosarcoma you are aware, and how will it appear on the x-rays, sunburst appearance, rising sun appearance, the malignant tumor appearances, all right, as well as one thing which is very important for you to remember in relation to the osteosarcoma are the associations. They are going to ask you about the associations, like it is related to retinoblastoma, Lee-Fromeni syndrome, Rothmund syndrome, all right. So these are the associations that you have to be aware of. And second thing about osteosarcoma, very importantly, that you should be knowing is that what are the causes of secondary osteosarcoma, all right. Causes of secondary osteosarcoma, like Paget disease, chronic radiation exposure. These are the causes of secondary. Even chronic osteomyelitis can result in osteosarcoma. These are the causes that you have to remember. Then even bone island, chondromas. So these are the tumors which can be converted into secondary osteosarcoma. Even the GCT can be converted into secondary osteosarcomatous tumor. So these are the causes of secondary osteosarcoma that you have to remember. Onion peel appearance on the X-ray is actually the periosteal reaction to that primary tumor, that is Ewing sarcoma. Ewing sarcoma is something that on the basis of which you will get a one-liner that all of the following are the features of Ewing sarcoma except. This is one question which is expected in the form of a spot diagnostic question. This will just give you an outgrowth as a tumor appearing from the metaphysis of a young individual where the growth plates are still visible. Then answer for that question would be osteochondroma, all right, osteochondroma or exhaustosis. And this is again a topic of importance. Osteochondroma related or exhaustosis related questions are in trend. They can ask at any point of given time. I mean, what are the complications? What are the chances of malignant transformation? If it goes malignant, then what are the clinical features? Because this is one such tumor which has got the characteristic of not going or of not growing beyond the skeletal maturity. Once the skeletal maturity is attained, the tumor will stop growing. On the other hand, the enchondromas, you have to go before sitting in the examination, you have to remember everything related to enchondroma, particularly the two important syndromes associated with this. One is Ollier and the other one is Maffucci syndrome. This Ollier disease is something which you already are aware of, like it is multiple enchondromatosis. Maffucci syndrome is multiple enchondromatosis along with the cutaneous hemangioma, all right, and the possibility of malignant transformation is as high as 20 and 40% respectively. For Maffucci syndrome, the possibility of malignant transformation is as high as 40%, all right. So, and finally the osteoid osteoma. You already are aware that osteoid osteoma is basically a small nick. It is a nidus in radiolucent nidus within the long bone cortices, the osteoid osteoma. And osteoid osteoma related questions are going to be straight away, like the pain is more at night, which responds to the indomethacin, which responds to aspirin, all right. So basically any COX inhibitor given, it will have a dramatic response, because the lesion of osteoid osteoma, it contains prostaglandins and cyclooxygenases. The second point of importance related to osteoid osteoma is the management. That means the treatment of osteoid osteoma. You know, today percutaneous thermal ablation, all right. So thermal ablation by the cautery is considered to be the treatment today. Means for every osteoid osteoma, you need not to excise the tumor by opening it, all right. Now, quick understanding of how the angles around the joint could be given to you in the form of the x-rays. They will give you the x-ray and they will construct the joint. You know, calcaneus, if they construct a joint around the calcaneum, then it could be Bowler angle or it could be Gisane angle. All right, the Bowler angle is or has to be up to 90 degree, means it is less than 90 degree. If the angle which is constructed around the ankle joint is less than 90 degree, it is Bowler angle. But the angle, if it is more than 90 degree, it is considered to be crucial angle of Gisane. All right, they will just give you the x-ray where they will construct the angle. If the angle around the calcaneum is less than 90, it is Bowler. If it is more than 90, it is crucial angle of Gisane. You just have to identify these two things. What is the bone around which the angles are constructed, and what is the value. Second is talocalcaneal angle in children. Now, in case if it is constructed in case of a child where you can very easily see that this is the x-ray of the child, then this is Kite's angle. It is not the Bowler or the Gisane's angle. Next, if the angle is constructed around the elbow joint, then it is Bowman angle. All right. If they give you the x-ray and in that x-ray they construct the angle and then they will ask you what is the name of this angle, answer for that question straight away would going to be Bowman angle. Then spine, lateral deviation. You know, if there is a laterally deviated spine, that means a scoliosis, a scoliotic abnormality, and they construct the angle. The name of the angle is Cobb's angle. All right. The name of that angle is going to be Cobb's angle. So these are the angles which we are expecting. They will simply construct the angle and then they will ask you everything related to it. You know, CTV is something that you have to revise before sitting in the examination. Yes, it is extremely important. They can ask anything related to CTV. They will ask about the deformities. What are the principal deformities? They will ask about the management. They have already asked about the treatment which is related to Ponseti and the Kites and what is the difference in between the two. All right. Remember, it is always the Ponseti method. As far as the splints which are required for the maintenance of the correction of this deformity is DB splint or Steenbeek foot abduction brace. So these are the things which you have to be aware of, because it is considered to be the most common congenital abnormality seen in orthopedic practice. You will encounter a patient with the CTEV every time or any time in your postings. All right. So you should be aware of counseling the patient, what the management is, or how to perform it, or how to deal it with. All right. So Ponseti method is something which we have already discussed. In hundreds of the videos are there, and you should be aware of, like, Ponseti method is the method of choice for the management of a CTV in case of a newborn. And these are the deformities: the equinus deformity, inversion deformity, forefoot adduction. There will be the foot in equinus, that means plantar flexion. It will be in forefoot adduction. It will be in inversion. There will be internal rotation of the tibia, and there will be a varus deformity, that means a combination of the deformity at the level of the foot. All right. So be ready for this CTV. Yes, related to this, there are 3 questions which are likely to be kept in your examination related to this topic, that is developmental dysplasia of hip. So the first one is, what is the screening investigation in newborn? You know, in case the child is just born, what is the screening investigation? Answer for that question is going to be USG, that means ultrasonography. Second is, what is the first sign of DDH, and that is limited thigh abduction. That means limited abduction of the thigh. That is the first sign of DDH. You already know what is the Ortolani test and the Barlow test. And finally, the third one is that the X-ray findings. You know, you will draw a line through the triradiate cartilage, which is known as Hill-Jenner line. You draw a line through the outer margins of the acetabulum, that is known as Perkins line. So what you can very clearly observe over here, that the head of the femur on a normal side is in the inner lower quadrant, while the head of the femur in the abnormal side is in the upper outer quadrant. Alright, so this is how the X-rays are going to be identified related to this condition, that is DDH. I mean, highly unlikely, but if at all they ask anything related to DDH, either they can give you the X-ray, they can give you the first sign, they can ask for the screening investigation, that is USG. Why screening investigation is not MRI? Because the placement of the child in the MRI after birth is difficult. Point number 2, why X-rays are not considered to be the screening investigation? Because the head of the femur and the acetabulum, both of them are cartilaginous at the time of birth. So the real relation in between the two cannot be observed. And then finally, what is the diagnosis which is provided to you in this question? They gave you the X-ray, they gave you the image of an individual who is having two different level of the scapulae. You see, the scapulae on the left side is higher, the scapulae on the right side is lower. The first thing that might hit you is that we are looking at winging of a scapula. No, this is not winging of a scapula. Winging of a scapula means both the scapulae are at the same level. It is only that the other scapulae are more prominent compared to the other one. Alright. It is basically the Sprengel shoulder, which is also known by the name of high-lying scapula. It is basically the Sprengel shoulder, which is known by the name of high-lying scapula or incomplete descent of the scapula. So hope everything is clear related to this particular topic, and hope this revision is going to be of help as far as your future examinations are concerned. All the best for your examination. And yes, remember, the examination of the hip, the segment that we have discussed, the differential diagnosis that we have discussed, the nerve injuries that we have discussed are going to help you out.